thank you to everybody for coming. I know it's literally a perfect Saturday outside, and it means a lot. This is hopefully meant to be very, very interactive. So we want to make sure that we're addressing all of the issues facing the patient community and caregivers, and hearing the questions that you guys have that maybe we don't do a good job answering in the clinic in the time that we have. So tried to bring together a program related to comments and things that patients have raised. So we have going from sort of early detection, why do people get this cancer? What can we do to maybe find it earlier? Then transitioning to sort of key issues around nutrition, which is a very, very common thing, especially people who've had surgery. So one of our surgeons is going to talk about what is gastric cancer surgery, what are the sort of standards. And then we'll talk in the afternoon a little bit more about treatment. What are the new treatments? How can we do better with this disease? But please ask questions. People online can ask questions. People in person can ask questions. We want to hear from you guys because we got a really good panel. So I'm going to start by just playing a brief introductory video because we really cannot do this without partnering with a wonderful nonprofit like Debbie's Dream, and of course the sponsors that support them. So I'm going to play a little bit of an introductory video to the foundation, and then I'll kick it off with Dr. Chan talking about risk factors.
At Debbie's Dream Foundation, Curing Stomach Cancer, our mission is simple but powerful: to raise awareness, fund groundbreaking research, and provide unwavering support to patients and families worldwide. Since our founding, we have been driven by one goal: making a cure for stomach cancer a reality. Our advocacy efforts have led to nearly $47 million in federal research funding, paving the way for a brighter future for those affected by stomach cancer. Every February, we bring together advocates for our annual Capitol Hill Stomach Cancer Advocacy Day, where we amplify the voices of those affected. We're proud of our recent victory. Thanks to our incredible advocacy, the Department of Defense has protected funding for stomach cancer research. Additionally, we secured language in the fiscal year 2025 National Defense Authorization Act to mandate H. pylori testing in the U.S. Armed Forces, an essential step toward early detection and prevention. Since 2014, we've partnered with the American Association for Cancer Research, AACR, awarding over $2 million to groundbreaking researchers. In the past year alone, we've directly funded $250,000 to Massachusetts General Hospital and awarded a $551,880 fellowship at Memorial Sloan Kettering to support transformative research in gastric cancer. Our global reach continues to expand as we work with Kibunukai to advance education and support for Asian and Japanese communities. In 2025, we'll host an international symposium in Tokyo, Japan, in partnership with the Japanese Foundation for Cancer Research and Kibunukai. Last year, we hosted our first international symposium in South America, tackling gastric cancer awareness in regions with high prevalence. Through our Health Equity Initiative, we're working to eliminate disparities by partnering with community organizations to promote early detection and education in at-risk populations. As we plan ahead, Debbie's Dream Foundation remains committed to advancing education, fostering innovation, and supporting patients worldwide. Together, we can make Debbie's dream of curing stomach cancer a reality. We are excited to introduce new programs aimed at empowering patients, doctors, and researchers alike. Our new podcast, From the Gut, Real Talk on Stomach Cancer, brings survivor stories, expert insights, and advocacy conversations directly to our listeners, spreading awareness and education to a global audience. Cooking Up Fresh is our latest initiative to help gastric cancer patients improve nutrition through live cooking demonstrations in partnership with HelloFresh. The program provides free meal kits where registrants can cook along at home and have their dietary questions answered. It builds on the success of our Meals for the Stomach Cancer Patient series, led by Emmy-nominated chef Nathan Lyon and Mary Eve Brown, RD, LDN, CSO, Clinical Nutrition Specialist. These cooking programs provide critical dietary guidance to patients at all stages of treatment. Our Doctors on Call program connects patients directly with gastric cancer experts for live, real-time Q&A sessions, ensuring that every patient has access to personalized guidance on their cancer care journey. Our Patient Resource and Education program, PrEP, continues to offer peer-to-peer mentoring, ensuring no one has to face this journey alone. As we continue to grow, Debbie's Dream Foundation remains focused on advancing education, supporting innovation, and aiding patients and caregivers around the world. With more than 200 advocates on Capitol Hill, new and ongoing research grants, and a commitment to health equity, our work is more impactful than ever. Learn more, get involved, and help us continue to change lives. Visit www.debbiesdream.org.
Someday, I promise the Debbie's Dream people that I will get to the Advocacy Day on Capitol Hill. It's a great experience in February. I will do it. All right, without further ado, to keep us on time, I'm going to let Dr. Chan introduce himself and talk about risk factors. And then at the end of this, please feel free to ask any questions that you want, and I'll try to get us on time.
Well, thank you, Sam. It's really a pleasure to be here and have this chance to talk to all of you about risk factors for gastric cancer. Before I start, I really want to thank Debbie's Dream for sponsoring this. I think it's really critical that we have groups like this to really advocate for gastric cancer patients and gastric cancer researchers, because there's so much we don't know about gastric cancer. We're only just starting to scratch the surface, and we really need to do more to do what we can to both prevent the disease and also achieve a cure. So thank you very much for your support. So I'm a gastroenterologist, and for many of you who are either gastric cancer patients or caregivers, gastroenterologists are typically one of the first doctors you meet that really sort of guide you through the diagnosis of the disease, and eventually also play a significant role in managing you through the disease in the initial stages. And one of the things that I want to drive home is that gastroenterology also is the area where I think we have the most potential for impact when it comes to areas like prevention. And I think there is really now an increasing emphasis on prevention, because it's really very clear that through prevention, we can really make significant inroads in reducing the incidence of gastric cancer and really helping more people achieve a cure. But one of the main questions that people ask around gastric cancer when they're first diagnosed is, why did I get this disease? And so I want to take you through what it is we know about gastric cancer risk factors, recognizing that these are not risk factors that apply to every patient. There's certainly certain risk factors that do maybe resonate with some of you, but for many of you, it's still quite unclear as to maybe why you or your loved one may have gotten gastric cancer. So I don't pretend this to be a one-size-fits-all type situation, but it's definitely giving us some perspective on what are the broad, big picture risk factors for gastric cancer. And by learning more about those risk factors, we can understand more about how we can prevent the disease. So just to start, I just want to very briefly take you through what it is we talk about when we discuss gastric cancer in terms of anatomy, and how that sort of helps us think about subtypes of gastric cancer, because risk factors do differ by subtypes. So the basic anatomy of the stomach is as shown here. And let's see, is this, you can see your pointer? It's a virtual pointer. I'll use a virtual one now. It can be broken up into two basic subtypes of gastric cancer. One is sort of proximal gastric cancer. When we say proximal, it means gastric cancer that's closer up to where the esophagus and the stomach meet. So proximal gastric cancer is in this location. And then a distal gastric cancer is a gastric cancer that's more down here in the body of the stomach, or the lower part of the stomach. And we think also about two major tissue subtypes of gastric cancer. The first subtype that's the most common is this subtype known as intestinal type gastric cancer. And this typically results from normal stomach lining, or what we call gastric mucosa, developing into an inflammatory state known as gastritis. And that gastritis can over time sometimes lead to a situation called atrophic gastritis. And atrophic gastritis can in turn develop into precancerous lesions like intestinal metaplasia and even adenomas or polyps. And then that can lead to intestinal type gastric cancer. So this is sort of the most common type of gastric cancer, or intestinal type gastric cancer. In addition, we know there is another major type of gastric cancer, which is called diffuse type gastric cancer. And this is a disease that we understand very little about. And we also don't really understand much about the precursor lesions. We know that we don't see this sort of typical cascade of events between normal lining leading to gastritis, leading to these precancerous lesions. Oftentimes we see very normal appearing stomach, and then it just proceeds quite quickly into this very diffuse type gastric cancer. So that's a very big challenge therapeutically and also diagnostically, because it's very hard to detect gastric cancers if you don't have some of these early precursor lesions. So what we've been interested in doing here at Mass General is trying to understand more about these different types of gastric cancer and how we can understand more about this so that we can start to develop opportunities for screening and prevention. A little bit about the epidemiology of gastric cancer. We know it is the 5th leading cause of cancer globally, so it's actually quite a common cause around the world, but you don't hear a lot about it in the US, but it is something that's definitely a leading cause of cancer around the world. The 4th leading cause of cancer death. It has a very poor survival rate globally. It tends to be more common in men, and also there is a rising incidence of early onset gastric cancer, meaning we think more and more younger people are now being diagnosed. And so that's something that we're trying to understand more about as well. To take you through the geographic variability, and this is, I know, a little bit hard to read, but you can see there's a lot of variation across the world. The incidence is much, much higher in Asia and parts of Eastern Europe as compared to North America here in the US. So the incidence rates are much, much higher in Asia. So it is important, as we heard in the video, for us to partner with people who are interested in gastric cancer research and also interested in advocacy with other partners across the world, including in Asia and parts of Europe. It's a very unusual cancer in Africa, but we clearly know there's a lot of geographic variability, which gives us some insight into some of the various risk factors for gastric cancer. Specifically in the US, it's the 15th leading cause of cancer. So it only represents a small percentage of cancers in the US, 1.3%. Survival rate is also poor in the US, but a little bit better than globally, 36%. And we know that there are stark and persistent disparities, and I'll go through that very briefly. We know there are disparities by immigration status. We know foreign-born individuals in the US have higher stomach cancer mortality rates compared to US-born individuals, about a 2-fold higher rate of stomach cancer. And we know that, for example, not speaking English is a risk factor for gastric cancer. So being a recent immigrant and being from a part of the world, in particular from Asia, is a significant risk factor for gastric cancer. These are the incidence rates by race. And so incidence is the sort of how often you see it in the population. Mortality is how often people die from gastric cancer. And you can see here the incidence rates are lowest in whites and highest in Hispanic and Latino populations, Black populations, Asian Americans, and also American Indians, Alaska Natives. So there is a lot of differences, not only in geography, but also by race, ethnicity. What do we know about risk factors for gastric cancer? You may have heard in the video the importance of thinking about H. pylori. Many of you know H. pylori is a bacteria that can lead to gastric cancer in a small percentage of people. So being chronically infected with this bacteria is a risk factor. We know that certain health conditions like chronic gastritis, which I mentioned is this sort of inflammatory condition of the stomach, can lead to gastric cancer. Of course, there's a lot of folks that have chronic gastritis that never have a problem, but it is considered a risk factor because a small percentage of people with chronic gastritis do develop gastric cancer. We know that family history is a risk factor. Having a first-degree family member with gastric cancer is a risk factor. And we'll talk a little bit more about genetics in a moment. And then we know that there's certain sort of lifestyle and dietary factors that are risk factors. We know salt and salt-preserved foods are a risk factor. Being overweight, obese is a risk factor. Heavy alcohol consumption is a risk factor, and also smoking. So these are what we know about risk factors. And again, they don't apply to every patient. Not every patient has some patients have none of these risk factors. Some patients have many of these risk factors. And also we know they're not risk factors such that they are, in any way predictive to any great extent in a single individual. So we all, of course, know many people that may have multiple of these risk factors that never develop gastric cancer. So it is something that we think about when we ask the question, why did I get this disease? But again, our understanding of this is incomplete. And we also know that we have to do more research to kind of understand among these risk factors, what are most important in certain populations, and are there certain genetic backgrounds potentially that interact with these risk factors? In other words, if you have a certain genetic susceptibility, is having some of these risk factors much more additive or much more significant in inducing risk for gastric cancer? Briefly about H. pylori, many of you know it is a bacteria that's quite common. It's probably something that a lot of people acquire as children and maybe carry into adulthood. Oftentimes does not cause any symptoms, but it is the strongest known risk factor for gastric cancer. It is classified by the International Agency for Research on Cancer as a class 1 human carcinogen. We know that it probably is associated with about 80 to 90% of this sort of non-cardiac gastric cancer or these distal gastric cancers. And there is very good evidence that if we eradicate it, meaning if we treat people who have H. pylori, you can prevent the disease significantly. So it's very important for us to do H. pylori screening in the right populations. We know that there is a lot of racial ethnic disparity in H. pylori associated diseases. And that's, potentially explaining why certain populations get more gastric cancer is because they have more infection with H. pylori. And that's illustrated here. We see that the prevalence of infection of H. pylori is higher in East Asians and Hispanics. About 20 to 25% of people with this ethnic background do have H. pylori, as compared to less than 10% of whites. And so that could explain why we see this difference in stomach cancer incidence. It's because there is this difference in H. pylori infection. A little bit more about diet. So we know, again, certain dietary practices around the world may increase risk. We know that particularly in East Asia, there's associations with eating certain preservatives and having certain salt preservatives in your food. Also, with respect to even dietary habits in the US, we know that there is an association with meat intake, and also in particular eating meat that's been grilled or barbecued or cooked at high temperatures, because that can induce production of certain carcinogens in the meat itself. So these dietary habits may contribute to risk around the world. We know, broadly speaking, that there is an association with diet quality. So the quality of your diet, meaning if you eat a high quality diet, you have a lower risk of gastric cancer, and that means less processed food. And also, if you don't consume a lot of fruit, and if you don't have a lot of citrus fruit in particular, that may raise your risk at all in general. So why are risk factors important? Well, obviously, if you understand what are potential risk factors, these are things you may want to potentially modify to reduce your risk. And again, this is something that is maybe particularly important in individuals that have a family history of the disease, because we think some of these environmental risk factors may play a greater role in people that are genetically predisposed. So in terms of what we call primary prevention, sort of how do you prevent getting the disease in the first place? Reducing risk factors is one way, and certainly improving our ability to diagnose people with H. pylori and treat them. With respect to diet, we know that if we can improve access to healthy foods, that certainly is a step in the right direction. If we address concerns around obesity, that will also reduce potentially the incidence of stomach cancer. If we encourage smoking cessation and also combat poverty, and we know that, again, a lot of social and economic inequities can contribute to gastric cancer risk, both by preventing people from getting access to healthy foods, but also potentially putting them in environments where there's more exposure to certain things. For example, H. pylori is very closely related to socioeconomic class. And so certainly we understand that there is underlying biological reasons for why things like poverty, socioeconomic class can lead to higher gastric cancer risk. Then we need to think more about screening, and that's what I consider secondary prevention. We know that screening for gastric cancer is not done routinely in the US. It's because the incidence of gastric cancer generally is low. So you need to screen a lot of people in the US population to capture a small number of cases. And so from an economic standpoint, it's never really made sense to introduce widespread population-based screening in the US, which is a contrast with what they do in Japan and Korea and countries where the incidence is quite high, where gastric cancer is much more common and where screening makes more sense from a cost-benefit analysis. But we do know, as I mentioned, that there are, again, these very large disparities in incidence in the US. So we have very high incidence, for example, in Asian populations, in particular, foreign-born immigrant populations. So are these people maybe that should undergo screening? And there's a lot of research being done in this, and I think there's increasing evidence that it does potentially make sense to screen people who are first-generation immigrants to the US that come from high-incidence countries like the Far East. And there have been efforts in various parts of the country in certain states to really try to make this routine practice. But the lack of screening guidelines, in these high-risk populations in the U.S. does make it more likely that people are diagnosed at later stages in the U.S., and that's certainly been a reason for why mortality is higher in the U.S. So we do have precedent for some more intensive screening in high-risk populations, and so there needs to be, I think, more work done in this area as well. In addition, as I mentioned, we have good evidence that screening works. It seems to be cost-effective if we do screen high-risk populations in the U.S., and there is good evidence that it does improve outcomes and reduce mortality in the countries that do have screening programs. And then finally, I think we want to think about how we can better do screening in high-risk populations that are defined either by immigration status, but also by genetic background. We know, as I mentioned, certain types of gastric cancer have a strong genetic predisposition. The hereditary diffuse type gastric cancer is something that is oftentimes genetic in origin. There is an association, for example, with specific gene mutations in the CDH1 gene. So these are populations that already have screening, but we need to develop kind of better ways to screen these populations because the screening is still quite insensitive. And you'll hear a lot more about this in Dr. Drew's talk after mine, where we're thinking about new ways to screen in more sensitive ways and doing clinical trials to test some of the most promising modalities for screening. And that's a central part of the research we do here at Mass General. So that's something that we're actively working on so that we can really start to really move where we are in terms of clinical practice. Like in the US now, many patients who see me in the GI clinic are diagnosed at this point of the cascade. They already have cancer when they're diagnosed, which is to say that they've already had the tumors develop, and oftentimes they're quite advanced. And we have to really start to do more in the way of therapies like surgery and other modalities. And so we know that that is something that we can do and that can help patients. But if we can move this to an earlier time point in the cascade and start to diagnose people at these earlier stages when they're even early before they start to develop precancers or even at the precancerous stage, we can start to develop an opportunity to intervene at an earlier point where cure is much more possible. And so that's where we're starting to develop modalities around testing early for gastric cancer using blood-based biomarker screens or advanced imaging approaches. And you'll hear more about that in a moment. And then last, I think we want to just emphasize how important it is for us to continue to do research and funding. What I've talked to you about up to now is what we know about gastric cancer, but there's still so much we don't know. We don't know a lot about risk factors that are still yet to be determined. We don't know how to really sort of think about risk in the context of genetic background. And we also need to do more work in trying to understand who do we adopt some of these prevention modalities in, who do we target prevention toward, who do we, for example, start to screen in a more intensive way. So we need to do more research. And to do that, we obviously need funding, and that's where we need help from folks like Debbie's Dream and patients and folks that really are personally affected by the disease. We know that gastroesophageal cancers are incredibly understudied and underrepresented, for example, in global clinical trial activity, despite the fact that there's so many people impacted by the disease. Just for an example, this was a really interesting study where they looked at the ratio of funding to lethality of the cancer, meaning how much funding is being put forward to the cancer based and according to how lethal it is. And stomach cancer is at the bottom, meaning among cancers that are the most lethal, they get the lowest amount of funding as compared to, other cancers where lethality is not as high. For example, breast cancer, but the funding for breast cancer is 180-fold higher than it is for gastric cancer. So we really need to do a lot more in this space. And so certainly working with our legislatures and really working with nonprofits to improve this situation is going to be really critical. So here are just some takeaways. First of all, gastric cancer is really a global disease, and we know that it affects lots of different individuals across the world. But in the US, even, it affects specific communities, but certainly, to some extent, all of us are at risk. And we know that there are certain known risk factors for gastric cancer. We know about H. pylori. We know about diet, smoking, obesity. We know social determinants of health are really critical in the way they interact with some of these risk factors. But there are efforts now to really make this a preventable disease. First, by knowing more about risk factors, we can reduce those risk factors in individuals. We can do more to screen high-risk populations. We can develop better screening modalities, in particular, to target those people that have high risk, to really more sensitively detect the disease when it is more curable. And we really need to increase funding efforts. And so we need to partner with our legislators and also with our nonprofits to really make sure that we give gastric cancer research a really high priority. So with that, I want to thank you for attending, and I'm open to any questions.
Thank you for setting the stage. Certainly that last graph is pretty scary. And I actually hadn't seen that one. To keep us on time, probably have time for one or two questions. If anybody has a question for Dr. Chan, I also put his cell phone at the bottom of the brochure, so you can text him, later. No. Yes.
Chan, Nick Scores, I'm a patient. Why isn't there more screening? I noticed several couching terms in your presentation. There's a precedent for screening select population. You just mentioned high risk, only screening for high risk people. I understand in other parts of the world, there is standard screening, much like a colonoscopy. Why isn't that happening here?
Yeah. So it comes down really to the underlying risk of the population. So across the US population as a whole, again, not considering specific populations or subgroups, the incidence of gastric cancer is quite low. So you need to screen a lot of people to pick up one case. And so, when you look at it from that perspective, quite simply, it comes down to, do we think that the cost of doing that kind of population-based screening is worth the gain? And obviously, for the individual patient that gets that cancer picked up, it made all the difference in the world. But if you're looking at it from a public health standpoint, insurers and also, the sort of expert bodies that make decisions about screening have decided that from a cost-benefit perspective, it doesn't make sense for us to devote resources to screening the whole population because, we live in a world of finite resources. So that's really the underlying reason for why we don't do it in the US, whereas in other countries where the incidence is much higher, and for some of these countries, gastric cancer is much more common, not much more, but more common than colon cancer. They do, screening for gastric cancer, but do less screening for colon cancer. So it is sort of based upon the total incidence of the disease in a given country.
Yes.
Segue on that, but what about H. pylori? Like that's a pretty low hanging fruit. So primary care.
Yeah, same. There isn't any sort of widespread guidelines around H. pylori screening in the US. You would think that would be, again, a lower bar because it's not expensive, but it's just never been something that has really taken off. And I suspect it's because, there hasn't really been a lot of because there's so many people that are H. pylori infected that never get gastric cancer. So that linkage has not always been very, very strong. And so I think people don't really view it from the lens of we need to do this to prevent cancer. And I think that that's why no one's really paid attention to it. But it is a good point, and I think more people are thinking about that in particular, doing much more targeted screening in high-risk populations as well.
Awesome. Yeah, we get sometimes in clinic, we get people where they're the diagnosed with the cancer and they had a H. pylori that was positive, and then but their brother's not our patient, so we can't like order the test for their brother, even though that would be like a nice, simple way to do it. All right, that was perfect. I think we're pretty much on time, so I'm gonna thank Dr. Chan. Now I will turn it over to Dr. Drew, who's talking about some cool stuff. Thankfully, it's a little bit farther after breakfast. It's got some good pictures for you guys. And you can also ask him anything about the Red Sox you want to know.
I won't pretend to know that much about the Red Sox and their problems, but I am a fan. Thanks, Sam, and thanks to Debbie's Dream for the opportunity to be here and speak with you all today. I'm a translational cancer researcher, meaning I'm a lab scientist who tries to understand ways we can use kind of classical scientific approaches to understanding disease better. And a lot of my focus has been on working with samples that we get from clinical trial patients or patients who are willing to donate samples via biobanks or biorepositories to our efforts. So I'm very thankful for patients and the advocacy around raising awareness for translational research, because it gives us an opportunity to take, rather than using mouse models purely or cell lines purely at the bench, we can actually try to translate this back to human populations. And we view that as a way to get to the goals that Andy was discussing for early detection faster. And so another secret is we all share slides. So in fact, I made this slide. Andy stole this from me. So but I won't spend too much time here, but what I will use is this is a nice overview segue for my presentation. I'll talk a little bit about the work we're doing on blood and stool-based biomarkers, so relatively non-invasive ways of screening and trying to improve early detection for cancer. And then I'm going to talk a little bit about the advanced imaging approaches that Andy referred to. My background has been in colon cancer prevention primarily. About 5 years ago, I got pulled into the gastric cancer world by Sam when we were challenged to kind of take what we were thinking about for gastrointestinal cancers, particularly lower gastrointestinal cancers, and apply them to gastric cancer. And particularly given what Andy had shown, this is a very understudied disease. And hasn't necessarily had the resources behind it as some of the more higher incidence cancers like breast or colon. And so really our goal, like Andy said, is to move clinical practice to the beginning of this spectrum rather than keeping it at the end where it is now. So if we think about a patient, maybe you, maybe a family member or friend that's developing a gastric tumor in their stomach unbeknownst to them, maybe they have symptoms, maybe they're asymptomatic. That tumor is still spreading things throughout our body, right? We have different signals that if we have sensitive enough methods for detection, we could, in theory, detect cancer earlier. And that's sort of the gold standard of where we're trying to move to in terms of early cancer and detection. Now, the GI system has the added value of having the gut microbiome and also having additional ways via stool to monitor what's happening within our gastrointestinal tract. So in addition to blood-based biomarkers, which have been used for a number of solid tumor types, we can also try to leverage stool samples to detect changes in somewhere within our gastrointestinal tract, but also understand how things like the gut microbiome, H. pylori, can be impacting our risk for these diseases and offering us new opportunities to try to prevent the disease. So 5 years ago, we launched the Stand Up to Cancer Gastric Cancer Interception team, which Sam is a part of and Dr. Chan is the leader of. And I was lucky enough to be pulled in on the biorepository side. And we brought together for the first time multiple institutions, including Samsung Medical Center in Korea, where we do have the ability to leverage a screening population that is actually actively looking among early stage disease. And we brought together the University of Chicago, City of Hope, the National Cancer Institute, and Columbia University. And we went into our freezers and we said, how many samples do we have? And any one of us on our own is very underpowered to be able to do any kind of meaningful discovery research because we only have handfuls of patients independently. So when we came together and we made a concerted effort to try to collect samples from our patient populations, within a very short period of time, we became the largest biorepository of gastric cancer samples, both from blood, stool, and tissue. And they are all centralized here at MGH now. And that's empowered us to create new collaborations with Johns Hopkins, we've brought in new partners now in the UK, in Mexico, in Taiwan, who are all contributing to the biobank as well, with the goal of being able to determine some of these early biomarkers and stool biomarkers for blood. And we made progress along the way. I won't spend too much time on this because this is published and you can find this work. But when I said I'm a translational researcher, we think translation in two directions. One is we start with patient populations, and then we try to figure out what's happening to them using tools at the lab bench that we have developed over many, many years. We also start with mouse models and work our way up to humans. And we say, okay, if we give a mouse cancer, how did they develop that cancer? And what can we do, or what happened along the way that we could leverage to try to detect cancer earlier? So working with Sandra Riom, and I'll show you some of her data in a second as well, at Columbia University, we actually identified circulating protein biomarkers in the blood, as well as within tissue, as well as that could be detected in stool samples from mice. And then using our biobank, we look for those same biomarkers that were associated with early tumor development in the mice. And we were able to see increased expression of some of those proteins in stool and blood. And so we view that as a way to develop an early diagnostic test. This is still very early days. We have to do a lot of clinical validation within this, but we have shown from a pilot and feasibility standpoint that we think this is possible. And then the other way we can tackle this is, what if we could just see cancer earlier, right? What if we could, as the cancer cells are developing within an individual, could we leverage molecular features of that tumor as it's developing, the earliest changes to the cells that are becoming cancerous? Could we find ways to see them better? And so one of the ways we've done this is, and we had taken our lessons from colon, pancreas, and esophagus, and applied this to gastric cancer as a part of the Stand Up to Cancer effort. This drug, pegylocyanine or LUM-15, I'll call it pegylocyanine, but I hate saying that word because it makes me stumble over my tongue, is developed by Lumicell, which is a company here just outside of Boston. And we've been long collaborating with them. They've recently been approved to use this drug for breast cancer tumor resections, to actually look at lumpectomy margins in real time in surgery and detect residual cancer cells to try to make sure they got all of it. And so in line with the funding, breast cancer was first, but now we think that this can actually be applied very robustly to gastrointestinal cancers. I'm going to show you why we think that is. So we started with mice. This is one of those translational studies. So we started with mice. We gave mice gastrointestinal cancer. This is colon here that we're showing. And we injected the mice with this agent, and then we took out their colons and we took pictures of them with our fluorescent cameras. And we could see very strong signal. That red signal is the brightest fluorescence intensity that's associated with tumors. And the part that I haven't quite explained yet is, under normal conditions, that molecular agent that we're injecting an individual with or a mouse with will not fluoresce. We will not see any signal of light off of it unless it interacts with a cathepsin, or what we call it, what is a protease, meaning it's a protein that's expressed on the surface of tumor cells. And it actually cleaves that molecule, and it allows it to fluoresce when we excite it with a certain wavelength of light. And so we first needed to check, is this really well established in gastric cancer? And the fact of the matter is, it's kind of a hallmark of a lot of solid tumors across the board. Like I said, it's a family of enzymes or proteins that cleave proteins that are interacting around the cells. It's definitely a feature of cancer because they use all of these different types of cathepsins to remodel the cellular environment around tumor cells to create space to grow, to get the signals they need to grow cancer. And like I said, it is observed in multiple different cancer types. So we think this has broad applicability across multiple different kinds of cancers. So in collaboration with Sandra Riom, again, at the University of Columbia, we looked within tumors in our mouse models, and these are both models of genomically stable and chromosomally unstable tumor types, where the genomically stable is more representative of what we call diffuse type cancer, or chromosomal unstable, which is more related to that intestinal type. So we see this in both types of cancer, where we see upregulation of cathepsins, different kinds of cathepsins compared to normal stomach, suggesting that we should be able to see tumor-specific fluorescent activity when we apply these agents. And then Sam very kindly looked within his single-cell RNA sequencing data set, and I won't go into the specifics of this, other than to say that we see very broad expression wherever we see these green or blue signals for the same types of cathepsins that we were seeing in the mouse. When we look at epithelial cells or the types of cells that create tumors in the ascites fluid of patients. So we were able to quickly look within patient samples and say, all right, we have the ability to move forward with this clinical trial. So we ran a feasibility study of peglokinine fluorescence-guided imaging, or PFGI as we call it, where we took patients who had been diagnosed with gastric cancer or were undergoing prophylactic gastrectomy and had a known CDH1 familial inherited mutation. We injected them with the agent about 2 hours before they were scheduled to undergo surgical resection of their stomach. And then we performed imaging of that stomach in the pathology lab after it came to us. And so this is a picture of me taking pictures of someone's stomach after it came to the pathology group. And if you're eating, I'm sorry, just there's going to be a few graphic pictures as we go through here. But I think it's really important to demonstrate the challenges we have in developing these approaches, but also sort of the positive outcomes that we think are coming with this as well. And so we can take different pictures of the stomach, and we can say, all right, in this picture, we know this is tumor, we know this is normal based on how it looks under white light conditions, and then we can confirm that working with pathologists. And then we can do some cool analytic things where we say, how often are we correctly calling tumor, tumor, and normal, normal if we use different thresholds of signal intensities? And so I'm pleased to say that we completed the enrollment for the neoadjuvant treated gastric cancer arm of this. So these were patients who had undergone treatment, then had surgery, and may or may not have had residual tumors, but we could look at their stomachs and look at residual tumor areas and see if we had a significant signal. We were about half of the population was female. This is a little older population because these are going to be more of the sporadic, non-prophylactic gastrectomy samples. And the average time from when we injected the patient to when we had their stomach in pathology to image was about 3.5 hours. And so here we did a dosing study. So as you can see, with increasing doses of peglokinine, we see increasing tumor-associated signals. So this yellow area of the stomach is what we've pathologically confirmed as residual tumor or the treated tumor bed. We can see very strong associations of signal even after we've had curative disease, suggesting that this is still remarkable to us to be able to identify where tumor areas are and sort of reside even after treatment, such that we could guide surgical resection more in real time, or we could guide minimal residual disease surveillance in the future. But we also got valuable information as to the dosing in this early study. Now, this is only 11 patients that we got data from, but the signals were very consistent. And so we also see increasing signal that's background on normal as we increase dose. So we were able to actually learn using lower doses in patients, which is great for the terms of side effects and everything else, actually allows us more sensitive detection of the tumors compared to the normal surrounding areas. And so this part of the study is still enrolling. We've thankfully seen less people in our clinic who are considering prophylactic gastrectomy or have known mutations right now. So it's been relatively slow enrolling. but also changes in how we treat gastric cancer now have made it so we don't have many people undergoing surgical resection before having some sort of treatment. So we've had 7 patients enrolled who have undergone a prophylactic gastrectomy. And so when we take a person's entire stomach and it comes to pathology and we open it up and we look at it, if we look at it, especially for diffuse type gastric cancers, if we know nothing else about this specimen, it looks normal. There's nothing that we can see here that points us to saying there's a tumor right here. There's nothing that says that we can see that. And the problem with diffuse type gastric cancer is that there's this percolation of tiny gastric cancer cells within surrounding normal appearing gastric cells. And so what we did was we imaged this entire specimen. Now, this is a patient who got the lowest doses of peglocainine. They had biopsy confirmed gastric cancer, but they could not see it. So they underwent a full total gastrectomy. So we imaged that whole entire thing. Now, pathologists then take that specimen and cut it up into pieces of tissue. This got submitted as 150 some odd blocks of tissue, and a pathologist reviewed every single one of those blocks to determine how many tumor foci are actually within that specimen. Now, again, this looks completely normal to our normal eyes. There were 124 foci of cancer within that stomach that we couldn't see otherwise. We couldn't see this with normal endoscopy. And so we mapped where those foci were, and we looked to see how that overlapped with our images. And as you can see, we see some brighter fluorescence intensity picking up here on this sort of overlay here, which tends to overlap with where we saw the densest foci of cancers, as well as those that they were not right at the surface, but they were within a few millimeters of the subluminal surface. And when we look, we can actually see that there are actual ratios of signal for that whole entire image, never mind zooming in on the specific cell, that would signal to us, yes, there is cancer somewhere within this smaller field. So on that data, we've developed an endoscope. And what we are trying to do is limit how the barriers to implementing this in clinic. So we've actually developed a system that can be passed through a standard endoscope that any gastroenterology practice might have, while still allowing them to pass tools so they can intervene in real time. They can take targeted biopsies. They could take additional tissue. They can tattoo areas of interest. They can do all of those things that they would need to do down one of the working channels of the endoscope. And we've developed our system to be able to get real-time images from endoscopy and still provide the standard white light visualization of the esophagus and the stomach. We've tested this within a pig gastric tumor model. So this is a pig's esophagus and stomach. We sewed in tumor cells into that stomach wall, and then treated the stomach with the agent, and we found that the fluorescence signal overlapped with those tumor cells. So we can create a real-time overlay that during endoscopy, a gastroenterologist could say, I want to target a biopsy right here, rather than relying on random quadrant biopsies as they do for surveillance now. So we have recently submitted to the IRB the in vivo study, meaning we will do this in patients in real time during endoscopy. We're enrolling patients with gastric cancer, established tumors at first that we can see, so we can gain valuable information about what signal means tumor is here versus normal. Patients will come in, we'll inject them with the agent an hour before their planned endoscopy, and then they will have a normal endoscopy like they always would. For surveillance, take some pictures, and then we will turn on the fluorescence version of this, and we'll take additional pictures and targeted biopsies and see if we can learn a lot about how we could detect this earlier. So this should be launched before the end of the year. We expect it's currently with the IRB for approval. Activation will probably happen sometime around November, and we're hoping we have first patient in before 2026, but it may be early 2026. So that I'm here on behalf of a big team of people, and their names are all up here. But we've been very fortunate to partner with additional foundations to help us on our journey to trying to improve early detection. But these people all were a big part of us even getting to where we are today. So thank you very much for having me.
Yes. Super cool stuff. So first of all, shout out to some of our clinic and research staff who I see are here. But basically, when someone's coming up to you when you're on your way into the operating room and they're like, "Hey, can we keep your stomach?" Like this is the stuff that we're doing with some of that, and can we collect your blood? And so we really can't do it without patients actually agreeing to participate in these kinds of things. But we can take maybe one or two questions, and I can start off like, what is sort of the pipe dream vision? So let's say someone gets they have intestinal metaplasia and they need to be on some type of monitoring plan. Like what is the sort of big vision hope for this?
Yeah, I mean, in terms of the imaging approaches, I think the idea is that gastroenterologists would have this tool in their toolbox to add to their surveillance approaches. So it may not be indicated in all patient populations, but it will allow us, especially for patients with CDH1 mutations, right, who are constantly debating, when do I go for that prophylactic gastrectomy? It would be a way to monitor tumor burden in real time, and such that you could make more selective decisions about when you might time that surgery for yourself, while trying to keep your risk relatively low. So we can reduce over intervention and we can time that intervention better. We see value in it in minimal residual disease detection. So after surgery, the surveillance that you undergo, especially for people who don't have a total gastrectomy, how do you make sure that another tumor hasn't arisen? And then, in terms of the question about screening in high-risk populations, we currently will require multiple endoscopies every 6 months or a year, depending on your personal risk factors. If you could more sensitively say, like we can for colon when you don't have a polyp, that your risk is really not such that you need to come back every year, we could use these tools to help us guide those surveillance decisions over time.
Yeah, that obviously that would be wonderful. I think it also is a reminder that, we all want things to change really fast, but this is like a several year effort to go from, you know, does the dye work? Is it safe? Can we do it in a pig? Can we do it in a person's stomach out of their body? And now can we do it with someone while they're actually in the endoscopy suite, which is obviously we'd love to be able to preserve the stomach, as you said.
And we're also, and I didn't mention it here, but we are looking at applying this to laparoscopic technology as well for the initial staging procedures that many patients who are diagnosed with gastric cancer then now undergo as a part of routine care to guide treatment decisions. We're not developing that scope. We're working with a laparoscopic equipment company to do that. But that is part of this trial, is to enroll 20 patients who have gastric cancer who are undergoing laparoscopic staging, and will also image the peritoneal areas for distant metastases as well.
Yeah. Yes. Question.
The beginning of your talk, Dr. Joe, but I know Dr. Klempner had mentioned in Korea that screening is much more rigorous because of the prevalence. And I'm wondering if you touched on what they use for screening, or, what stage they're at technology wise, and why they pick up so much earlier.
Yeah, so that's a really great question. I think Dr. Chan's talk had touched on this a little bit more. They have a higher prevalence of intestinal type gastric cancers, which may be more morphologically distinct at early stages where you could intervene, compared to some of these diffuse type gastric cancers for sure. They still rely on the routine endoscopic tools that we have now at our disposal. So they're not doing something radically different. We are not the only imaging approach that's being explored in this space. There are other methods like optical coherence tomography, which gives you sort of architecture of the mucosa as you're imaging it in real time. And we are collaborating with people who are leaders in that field to try to figure out how we could sensitively combine these approaches to even improve our detection further. But they're not doing anything different than what we're doing, other than that they're doing it in everybody, right? And their risk is higher, so they're capturing more cases than we are. So it is a question of the types of cancers they're developing, the more routine screening they're going under, but in combination with them being at increased risk compared to the US population as a whole, as to why they have more success at catching gastric cancers early.
Yes.
The CDH1. And
really struck me was your screen that had the stomach open and you can't see anything, and then but stuff was there.
Mhm.
And that's exactly what happened with me. So I went and had my stomach out, and then it was found later. What do you see? Who do you see the types of what kind of patients do you see using this new technology? I have there obviously there's CDH1 in my family, and there are people doing surveillance. Most of us have had our stomachs out. But who do you see using this? So somebody who is getting surveillance?
Yeah, absolutely. I mean, I think long term, what we would expect, especially for CDH1 carriers, would be, you know, and a lot of people are undergoing this surgery very early in their lives, right? So if you can improve quality of life, we see the same problem in colon with FAP patients and Lynch patients. They decide about colectomies or BRCA1s and mastectomies. The idea would be to more sensitively survey people, that we could say, all right, even though we saw nothing on biopsy, we saw this one area. Well, we could target those biopsies, right? That's the first step. But in the event of not needing to biopsy 125 times and find all of those foci, we could look and say, oh, actually, you were thinking about putting this off for a couple of years. You have a tumor load of 125 foci right now. We think you should probably accelerate that timeline so you don't develop cancer. Or alternatively, we screened you, we saw nothing, and we saw nothing on biopsy, and have more of a sense of, not a clean bill of health, obviously, you're still at higher risk, but we'll see you in 6 months and we'll see if we need, and then we'll start to think about this. Or it was clean, let's see you in a year and a half or 2 years rather than every 6 months. Right.
And I mean, the big question, when is this going to be available?
Well, as I showed you, it will be available now, soon, broadly available. That all depends on how successful the study is, right? And like Sam said, I've been at MGH for 10 years. The ex vivo study initially launched before I joined MGH as a postdoc. We've made massive gains in the last 3 years because of an infusion of funding between Stand Up to Cancer and some of these foundations as well. And Lumicell, when we first started working with them, was 4 people, and they are now a company. They have an FDA-approved product, and they've grown quite a bit. So we've seen this really from conception all the way to where it is now. Unfortunately, that's the world we live in, timeline for regulatory. But we're seeing it in patients as soon as this year, right?
I have a maybe last question for you. So maybe give everybody in the audience a little peek behind the curtain in terms of what it actually costs to do this. Because I think, to your point, one of the reasons we can't do this more broadly is limitations in funding. But like, to do a trial of 20 patients with this intensity, like ballpark numbers.
A trial like this costs us about $1.5 million to do a study where. And that is us doing it on the cheap. Generally speaking, we're providing resources that we're not costing for. There's patient remuneration. We have to pay for the OR time. We have to pay for the technology development. We've probably dumped anywhere between $100,000 and $200,000 just in getting better filters so we can reduce background, not real noise from the signal, to real sensitive tumor detection. So we're not calling something a tumor that isn't. So yes, money is a major obstacle along the way, but even small studies like this are still very expensive.
Yeah, that's why like Dr. Chan's graph was so tough to see, but also humbling, is things move faster in breast cancer. There's more money available for researchers to get access to do this type of work. All right, I think to keep us on time, that was perfect. Thank you, Dr. Drew. Now we'll move on. Perfect. All right, I'm going to bring up Rob Dunn, one of our dietitians. I think this person is usually the star of all of the symposium and probably will have the most questions. So, Rob, take it away, and then we'll have some questions for you. Yeah.
Right. Okay, great. That easy, huh? Awesome. Thank you.
Morning, everybody. Can everybody hear me okay? Awesome. It's really a pleasure to be here. I was honored when Sam asked. As he said, my name is Rob Dunn. I'm one of the clinical dietitians caring solely for patients with cancer at the Mass General Cancer Center. That's one of the advantages of our center is we have a team of dietitians that is, admittedly a little small, but we care only for patients who are actively receiving anti-cancer therapy, which allows us to really focus on the unique needs of those patient populations. So the way I want to kind of structure this talk is to talk about the role of nutrition generally in cancer treatment and then focus on gastric cancer and the ways that we can intervene from a nutrition and also a supportive care perspective to try to improve outcomes. So this is our small little team and our mission statement at the top there, which is really that our team is focused on caring for patients across their cancer treatment journey with a real focus on identifying, managing, and hopefully reversing disease-related undernutrition, or as we'll define later, malnutrition. I hope this isn't too academic or maybe basic, but I want to really define nutrition before we go forward. Nutrition is something that everyone has an opinion on because everyone needs it for their entire life. And so you'll hear a lot of things in the lay press, the media, from your friends, from your nephew who goes to the gym, from everyone about the right way to eat, the appropriate foods that you should eat all day, the things that you should never eat again, the ways that our food is good for us, bad for us. But at a building blocks perspective, what nutrition is the process of taking resources from the environment and using it in our body to do activities. So the process of bringing protein, carbohydrates, fluid, vitamins, minerals from the environment into our body so that our cells can do the work that we need them to do. When I teach students about this, I say that the role of a dietitian is to take all of the barriers from sun to cell to stuff. So we need to leverage kind of nutrition expertise to bring patients from an area of undernutrition where they're not getting enough from the environment, eating the appropriate foods so that they can do the types of activities, both at a kind of macro level, like running, and at a micro level, like fighting infection or responding to cancer treatment, that we need their bodies to do. So what is malnutrition? Kind of simple. It's when that process breaks down, when we're not actively or not kind of adequately bringing resources into our cells, and then we suffer ramifications from that. And specific to cancer treatment, there's changes to the way that our body utilizes nutrients during cancer therapy that increases or sometimes shifts the types of nutrients that are required to do that type of work, that stuff. So from a prevalence perspective, over the course of cancer therapy, 40 to 80% of patients develop some degree of disease-related malnutrition. This varies broadly depending on the type of cancer and the stage at which it is initially found. Gastrointestinal cancers are one of the highest rates of malnutrition incidence in patients with cancer, and gastric cancer is not an exception to that. 51% of patients who are diagnosed with a solid tumor, so not lymphoma or leukemia, are diagnosed at the time of their first clinic visit. And we know that nutrition intervention in context of cancer is the most effective when we implement interventions early. Why do we care about this? Malnutrition is related to or is correlated with really significant clinical outcomes. So the inability to adequately nourish yourself during cancer treatment is associated with increased rates of surgical complications, higher rates of needing to go into the hospital, and more frequent need for dose reduction of your chemotherapy or your prescribed anti-cancer therapy. And so it matters. What we really want to do is give patients the chance to be adequately nourished for the entirety of their cancer treatment so that they can respond as well as possible to the therapy that their oncologists have recommended to them. And so what I want to focus most of this talk on is the role of skeletal muscle mass in the management of nutrition across the cancer care continuum. So what we understand about nutrition is that the things that matter are maintaining your skeletal muscle mass and perhaps even accruing it over the course of your cancer therapy. And so what happens very often is that there are barriers that emerge early in the cancer care course, side effects from your prescribed treatment, perhaps some restriction of certain food groups because they don't make you feel good or you're nervous about the way that they interact with your cancer. And that degree or even like subtle restriction of calories and a deficit that leads to modest weight loss in periods of health can lead to really rapid decline in weight in context of cancer. So this study from China showed kind of the ramifications of that. So they looked at over 1,600 patients at a single center who had a planned surgery for treatment of their gastric cancer. And they looked at muscle health. Muscle health was basically how much muscle do you have, and does that muscle, is it strong? They measured it via a single leg extension. Very often in clinic, we'll measure how strong someone's grip is. But it's a measure of how strong the person's muscles are and how adequately they can perform the work that we want them to do. And people who had weaker muscles or less muscle mass had shorter survival after their stomach cancer surgery than those that had stronger muscles. We saw a similar thing at a different study out of China where they looked back at a group of patients. They looked at about 1,400 cases, and they looked at both surgical and non-surgical cases and found that patients who had severe malnutrition or kind of loss of muscle function had significantly shorter overall survival. And so I think very often when we think about nutrition and cancer, there's maybe a misconception that this is all kind of preordained and that there's not an opportunity to kind of reverse some of the undernutrition. But what we understand and are beginning to learn more about, it's a relatively new field of study. And when we talk about funding gaps, significantly underfunded, the role that nutrition intervention can play in reversing some of the kind of negative side effects of undernutrition across the care journey. So patients who, is this large enough? Might be a little small. That little, the lowest line, the patients with the worst survival in this study are patients who developed malnutrition but went without kind of targeted nutrition care. So those that suffered from malnutrition and didn't have any interventions to treat it, which unfortunately is somewhat common. The line above it, the light blue line, are patients that did become malnourished, but then subsequently received nutrition interventions, maybe targeted care from a dietitian or nutrition support or oral nutrition supplements like protein shakes. Those patients lived a statistically significant longer period of time than the patients who did not receive nutrition intervention. So there is hope in the role that our care can play in improving outcomes. So we'll talk just briefly about nutrition across the care journey. So like what nutrition looks like from the time of diagnosis through treatment and into survivorship. So what I always tell patients is when you're diagnosed with cancer, you have to put the phone down. There's lots of well-meaning people probably in your family and many others on the internet who are maybe not as well-meaning, who are going to tell you about food and cancer and the way that the two interact. What we know about what you find on the internet in terms of food and cancer is most of it is wrong. Some of it is wrong in a way that is just a misreading of the way we understand cancer and nutrition interact, and some is wrong because it's profitable to sell supplements to people. I never blame people for wanting to take nutrition interventions into their own hands because it's something that you can control during the course of your treatment. It's something that we all understand, but there are groups that will say things about food and cancer that we don't necessarily believe to be true. So 40% of recipes that reference cancer in this study looked at, so over 1,000 recipes, made references to preventing cancer. That's not something that we understand food at a micro level to be able to do. And 10% referenced curing cancer, which is certainly not something that we think food can do. And 80% made claims about the role of specific ingredients in fighting cancer. When we think about nutrition across the cancer treatment journey, I talk to patients about three things. I talk about protein, calories, and hydration. There's lots more to nutrition than that, but in context of active anti-cancer therapy, what we care about is maintaining muscle mass, and muscle mass is a recipe between these three things and exercise, which I'll talk about briefly. So I feel like I'm probably the 9,000th person that stood in front of a group and said, you need more protein when you have cancer. And I feel like as a field, we don't do a good job of saying what that means, like how much is more. I talk to patients all the time. It's like, I'm really focused on protein. I had an egg last week. And then I have, or I'm really focused on cancer. I have 300 grams of protein before noon every day because I have this huge shake. And the truth is really somewhere in the middle. So just back of the napkin math, these equations work for people at not extremes of height. So anyone between 4'7" and 6'5", this is a pretty good estimate. To determine the amount of grams of protein you need in a day, you multiply your height in inches by 1.5, your calories by 32, and then your fluid is roughly the same as the number of calories that you need. This is certainly different individual to individual. If you're taller, if you're more muscular, if you're more active, that's going to change the way that we think about how many calories you need. The amount of protein you need is actually somewhat fixed, and exercise can actually bring your protein needs down counterintuitively. But this is kind of a good place to start. And if you don't have someone targeting or someone really actively managing your nutrition during cancer care, these numbers can give you a good place to start. So let's say, hypothetically, the speaker is 5'11". The math for me would turn out to be about just over 100 grams of protein, 2,300 calories, and about 80 ounces of water over the course of the day. So that also is not how people, and certainly not how I think about food normally, right? The quantification of calories and protein is a little foreign. This is what it looks like in kind of a pre-surgical meal plan. So 3 large-ish meals, 8 a.m., 1 p.m., 7 p.m. You're getting your fluids in wherever you can, drinking water, throughout the morning. You have a cup of coffee with that. Maybe have a protein shake in the middle of the afternoon. It's from a logistics perspective, not of like symptom burden, it's pretty easy to get to 2,400 calories and 120 grams of protein just from a logistics perspective. We'll talk about post-surgery in a second. And then just briefly, I wanted to talk about exercise because you could have 500 grams of protein and, Arnold Schwarzenegger levels of calories. If you do not move, you will continue to lose muscle mass. And that is true both in health and certainly in context of cancer treatment. So the recommended guidelines for exercise are very much emerging. They're very new. There's only been a couple position papers over the last 5 years. But what we kind of understand is that you should move more than you sit, try to limit long periods of sedentary behavior. Even if you're not feeling great after treatment, try to get up off the couch, move around just a little bit, even a quick walk around the block. When you're feeling well, we want to engage in resistance exercise or something that moves your muscles twice a week. Doesn't need to be very long, 20 to 30 minutes. And then the target for aerobic activity is 150 minutes per week. That's a lot. Most people don't get there. But we know that even significantly lower levels than that, just with a modestly elevated heart rate, breaking a sweat, but able to have a conversation with the person you're jogging with, does make a difference. And so just briefly, because I'm not the surgeon in the room, the anatomical changes after surgery for management of gastric cancer changes the way that we approach meeting those quantitative nutrition needs that we talked about. So what does the stomach do, right, prior to surgical resection? What are the stomach's jobs? When I teach students about this, I say that it's a short-term storage facility. It's a kind of holding area for food. It allows us to eat a fair amount of volume at one time and go about our day. We don't need to necessarily eat so frequently because our stomach can hold a relatively large volume. Up to 1.5 liters is the average. But I mean, there are certainly people whose stomachs can hold far more than that. It acts as a KitchenAid mixer. It gets everything to the same consistency. So I can have a turkey and cheese sandwich and a cup of coffee, and neither of those things look the way they did when I ate them by the time they interact with my small intestine. The small intestine is where all the absorption is happening. It's a chemist. It adds acid and other digestive juices to get foods ready to be digested and absorbed a little bit further down our GI tract. And I think maybe most importantly, It acts as air traffic control. It controls the pace at which food and fluid interacts with the lower part of our gastrointestinal system. And pace is really important for symptoms. So how does surgery change this? If some of your stomach is removed for management of your cancer, the ability of your stomach to expand and hold a large volume of food is certainly diminished. The ability of it to move and mix things up to a kind of cohesive consistency also is diminished. The tissue that was producing all of those acid and the digestive juices and at the level of the stomach, there's less of that because some of the tissue has been removed. And you may be on medications that suppress some of the acid after the surgery. And the ability for it to act as air traffic control or slow down the passage of food from your mouth to your intestine, that's also impaired, may be impaired. And so how do we navigate that from a behavioral or a meal structure standpoint? We want to eat smaller, more frequent meals that are calorically dense, particularly I often tell patients 2 to 3 months after surgery. We don't necessarily need to focus on lower calorie, still high nutrient density foods. It's not the time for a salad, right? We need to focus on things that have lots of calories and deliver a high calorie per inch ratio. We want to separate liquids from solids to avoid feeling overly full. We need to chew foods very well because if you swallow a large piece of food and your stomach is fully intact, your stomach can churn and break that down into smaller pieces in a way that your small intestine will be able to absorb. After a surgery, that capacity is decreased. So you need to chew very well so the mechanical breakdown of food can happen earlier. We want to avoid very sugary liquids because that can draw water into our intestine, which can lead to that cramping, bloating feeling that sometimes is referred to as dumping syndrome. And then air traffic control. We need to eat slowly, sit upright when we sit. The pace of food through our GI tract is altered after surgery for gastric cancer. One thing that I want to say is that avoidance of low calorie, high nutrient density foods is not a forever thing. We do want to gradually add back fruits, vegetables to our diet as tolerated. It's just not the first priority after the surgery. So going back to this hypothetical person, 5'11", needs 100 grams of protein, 2,300 calories, 80 ounces of water. These numbers are true during pre-surgical treatment, and they are certainly true in the aftermath of a surgery. You need a higher amount of calories and protein to heal from the surgery that you just had. But the logistics are different. We need to eat more frequently. We need to integrate protein into all of our meals, not just the 3 main breakfast, lunch, and dinner. We need to find areas to add fatty foods. Healthy fats are perfectly appropriate, like avocado, olive oil, slices of cheese, nut butters, and avoid things with very high food volume for not a lot of calories. So the first person or prior to the surgery, this person was eating popcorn at night and having like a big entree salad with lunch. That's just not the same priority in the post-operative period. And then finally, I'll just say a little bit about nutrition and survivorship. So this is where some of the well-meaning people who make recipes who say, risk reduction are actually a little bit right. We want to avoid highly processed foods, sugary sweetened beverages, certainly alcohol and smoking after treatment for cancer as hopefully we live into survivorship. And we want to increase our intake of high fiber foods that are micronutrient dense, and avoid gaining excess body weight. The same exercise goals that we targeted during treatment are appropriate after treatment. And the goal is really to maintain a healthy body weight, continue to exercise, and find a pattern of eating that's comfortable for you after that treatment course. That is all I have.
That is awesome. So, Doc, sure, there's going to be a lot of questions, but I'm going to start with one that maybe you can talk to, because obviously it'd be amazing if every patient could have a dietitian on a regular basis. But tell a little bit about sort of like the staffing ratios, like how many dietitians are there for a patient? I've heard some kind of scary numbers.
Sure. So what we kind of have estimated based on the risk of malnutrition at the start of treatment and the, kind of productive capacity of like a well-trained dietitian is that a cancer center that treats like a mixed set of cancers should have roughly 1 to 200, one dietitian for every 200 new patient assessments. The national average is one dietitian for every 2,400 new patient assessments. And our center, unfortunately, is 1 to every 3,300. So access is certainly a problem. And that's why at our center, we try to cast a wide net. We're trying to develop group sessions where we can meet people's needs in like a kind of a mixed capacity. And certainly we want to provide people good information so they can do a lot of this work on their own. But yeah, access and kind of consistent exposure to expertise is a challenge. And that's where, people step in to fill a void.
Yeah, no, it's really unfortunate problem. Yes, I saw your hand.
Yes. Hi there. Jeremy Perry had a gastrectomy 5 years ago. Here with my cousin 2 years ago. My son just had his 2 months ago. So we are in the process of going through it.
Yeah.
With that number said, it changes my question a little bit because we weren't able to see a nutritionist after our surgeries, with 12 days here at Mass General as well.
Okay.
How do we get this information into the hands of the patient so that, because I saw that this was part of a curriculum at the bottom there, and it would be great information, right? So even with my son, 18 years old, not interested in any of this, right?
Yeah.
Interested in very different things. So we took pictures of everything because I need to send it home to him today. We aren't keeping track of it, right? And so how do we get it there so that folks can have this consistently starting on Monday when the next, gastrectomy takes place?
Yeah. I mean, I think that's a challenge for our team and something that we take seriously. I think that we are, given the fact that unfortunately on Monday I won't be able to double the size of my team. We're trying to integrate into clinics as soon as possible to try to create kind of standardized education materials. We're starting to do kind of group webinar sessions. I'm sure I can share the link with somebody who can get it in the hands of you. But yeah, we're trying to preach the good word and kind of go out and talk about the kind of tricky period, which is the start of pre-surgical treatment for maybe another 6 months after surgery. Hopefully then there's some adaptation and you kind of fall into a routine and nutrition can be less prevalent or less front of mind. But it's trying to work with our partners and the other disciplines to make sure that we're getting good information to people.
If I can help with that or this group, let us help.
All right. Sounds
Yeah,
good.
I know that like these lectures, which are obviously general advice, will like live on the Debbie's Dream website, I believe, or so it's not the individualized, that we want to do, but it's a start. Yes, Melanie.
Okay. I'm not going to scare anybody in the room. And just to give you a heads up, reactive hypoglycemia. I am a 17-year survivor living without a stomach and many other body parts. But 2 years ago, I started with reactive hypoglycemia, didn't realize it. We are finding that I run a bunch of support groups online for stomachless patients and for cancer patients. I'm also part of Debbie's Dream. We are finding that either the patients are getting it right out of the gate as soon as they lose their stomach, or it's happening later on. And it is something I have to tell you, it is a very difficult. You're talking to 3 people right here in the front row that all have no stomachs, and we are going through a hell of a time finding the right endocrinologist, finding the right dietitian. We're looking at everything you're telling us to eat, and we're going, that's a wonderful theory.
Yeah.
But in essence, it's really hard. It's very hard. I've changed endocrinologists. I've changed my primary care. I'm finally getting the care that I feel I deserve. I mean, I'm passing out. And so I think, we're all passing out. So it's not something that can't be taken lightly. You don't have to go into it. I'm just saying we want it on your radar. We want you guys to understand that we're having these symptoms. It may not happen right away, but it's happening later on, and it has to be addressed.
Yeah, no, thank you for sharing that. I think it's certainly something that we understand about the changing like flow and kind of pace of and like insulin release after eating. And our gastrointestinal tract is fully intertwined, right? The hormonal signaling from, ingestion to excretion is really complex. And when some element of it is altered and the pace of food entering the small bowel is different than what it's been for most of your life, the excretion of insulin or the insulin response to the meal can be exaggerated and early in ways that lead to hypoglycemia. So I think certainly the management is very individual. Some of it's going to be meal composition, and some of it may be kind of some other supportive care interventions. But I don't want you to think that it's not on our radar. It's something that we're trying to manage. It's an interdisciplinary approach.
You do feel alone. I just want you to know that. Okay?
Yeah. Yeah.
But we kind of feel like we're out in left field somewhere because they're looking at us like we have three heads. So, but it's very interesting you said about hormonal, because my oncologist is thinking that without the stomach, with the pancreas, he's thinking that maybe it's hormonal things going on, and I'm going to go to my endocrinologist and start inspecting that avenue of it too.
Yeah.
Like a diary, the best you can. Yeah. And a symptom diary. Yeah.
Yeah, we've done it all.
Yeah. I think that the driver of that is very individual. So it's hard to generalize, but it's certainly something that we understand is possible. And it is related to the pancreas getting mixed signals from the departure of food from your stomach.
I probably have,
I just have a really quick, so I still do a lot of difficulty finding a nutritionist that knows really what I need. I finally found somebody she's also treated my sister, so she's got two people going. We both don't have stomachs. Where should a nutritionist look to get information that you guys are working on?
Certainly, they're welcome to reach out to us directly, but most dietitians are trained as generalists.
Yeah.
And then it's career experience thereafter. So at our center, we train 12 new dietitians every year, and they get exposure to patients with these types of surgeries as well as others, and this type of cancer as well as others. It very much, I think I would look for someone who's cared for patients with cancer specifically, because there's most people entering the field of dietetics today are doing a lot of weight management or kind of chronic disease management, and the field is also contracting. So the availability is not likely to expand. But that said, there are people in the community. One of our dietitians sees people privately who do have some expertise. So it's not hopeless, but I would ask about their background in managing kind of surgical cases, because that's not something everyone
I'm seeing has actually dealt with this before specifically. But I'm just wondering with the new stuff coming out, like where they could find it and where they should, I guess I could contact you guys.
They're welcome to reach out to us. It's a relatively new field of study, so it's evolving.
Yeah, super big shortage. I mean, we refer all of our patients to our dietitians, and sometimes we still wait for a while to get a visit. It's a system problem. Totally agree. I think we may have time for one more question if there is any. Yes.
My surgery, and I found that it's really important in regards to nutrition, is a menu. Oh, thank you. Is a menu you can really actually see and take from that versus this is what you can have, this is what you can't have, and without amounts. So seeing that menu really gives a person who really doesn't know exactly what we're supposed to have, a good idea of what we should eat. So I would definitely, if you could, send that along with the brochures of all the things you send out to your patients. Right. Yes. That's really what helps.
See it and use it as a guide. Than it is to or go food shopping for it.
Right.
And than it is to try to make it up in your head.
Right.
Absolutely.
I think I want to think of it as a guide, right? I hate to say that I'm prescribing a meal plan to someone. I'll never do that in my career. Like what we try to do is provide a framework where you can,
the framework is really important for you to be successful. For me, that
totally.
Yeah.
There's a million ways to eat healthy, both pre and post surgery. There's cultural foods that I will never engage with in my whole life that are very healthy after this type of surgery. It's understanding the way the different kind of food components interact. Yeah.
Yes, thank you.
Yes, awesome.
My pleasure.
Yes, thank you. Now, you mentioned surgery, so now we will hear from one of our surgeons. So Dr. McKinley does a lot of these surgeries, a lot of them robotically. So you probably see some cool videos. Surgeons always like videos. And yes, take it away. Tell us about surgery for stomach cancer.
All right, thanks so much for having me today. It's a real privilege. My name's Sophia McKinley. I'm a surgical oncologist here at MGH, and my focus is on upper GI cancers. My favorite organ is the stomach, but don't tell the liver. It's a real privilege for me to share some information with you, although it sounds like a very informed audience. So I'll be spending some time describing laparoscopic staging and gastric or GE junction cancer. What I think of are the markers of high quality surgery, and then some suggestions or considerations when you choose a gastric or GE junction cancer surgeon. So I'm going to jump right in with staging laparoscopy. And I know this is review for most of you, but I just want to make sure we're all sharing the same language. Staging is the idea of figuring out where a cancer has traveled, if at all. And it's really important to figure out what stage a patient is, because we want to match treatment to stage. And the stage will also give us information about a patient's prognosis. And so I found that patients often get very frustrated when they first meet the cancer care team because they want to start treatment right away. And we usually pump the brakes and we do a lot of work on staging. And the reason is that we want each patient to get the best possible treatment, which means understanding their stage accurately. More review, early gastric cancer is when the cancer cells are only in the superficial layer of the stomach wall. The treatment is primarily to remove the tumor, either through endoscopic resection or surgery, and the prognosis is quite favorable. This is in comparison to locally advanced, or what some people call middle stage gastric cancer. In middle stage gastric cancer, the cells have invaded deeper into the layers of the stomach wall, or they've invaded the lymph nodes around the stomach. And we know that the best chance for cure for patients with locally advanced gastric cancer is to combine systemic therapy with surgery. And while our goal is to cure patients with locally advanced gastric cancer, there's a much higher risk of recurrence. Advanced or metastatic or stage 4 gastric cancer is when the cells have traveled beyond the stomach and its lymph nodes, and the treatment is primarily systemic therapy. And the goal of the treatment is primarily to slow the cancer. Rarely does it cure. So we have a lot of tools to understand the stage of someone's gastric cancer. We use CT scan, we use PET scan, but oftentimes we actually need to do a procedure to figure out the exact stage of the patient. This might be a special ultrasound that's done in the endoscopy suite, but sometimes we actually have to do an operation to figure out a patient's specific stage. That operation is called a staging laparoscopy, and it's typically used to figure out if somebody's locally advanced or metastatic. In this operation, the surgeon makes 2 small incisions on the abdominal wall. We place a couple ports, a small camera goes in, and it permits us to survey the entire abdomen. It's a general anesthesia procedure with an endotracheal tube. It's day surgery. I use only absorbable sutures, so you don't need to come back for a post-op visit. And it lets the surgeon see cancer that might be invisible on the CT scan or the PET scan. And even if the surgeon doesn't see anything, it also permits us to see cancer that's actually invisible to the naked eye. And the way we can do that is we'll actually rinse the inside of the abdomen with water. We suck that water out and we send that water to the pathology lab. And if the pathologists see cancer cells in that water, we also consider that to be stage 4 cancer. And then one of the things that I like about staging laparoscopy, it gives me a little bit of a sneak preview of what a person's abdomen is like for future surgical planning. So this is my warning for anyone who's squeamish. I'm going to start showing photos and videos. So if you don't want to see photos and videos before lunch, this is your cue to close your eyes. Okay. All right, so this is a couple of pictures that I took during a patient's staging laparoscopy. There was no evidence of metastatic disease on their CAT scan or their PET scan, and you can see there are all these little tiny drops, white dots, and this is all gastric cancer. This is sort of a zoomed out view of it, all these little tiny dots. This is the patient's liver, and this is the cancer itself, and you can see that it's grown all the way through the stomach wall. So this is normal stomach up here, and this is the cancer growing through. And then this is actually a video. Dr. Klempner knows surgeons. The video of a staging laparoscopy, has some pretty dramatic findings. That's the stomach. All of these white areas are gastric cancer. A lot of here too, above the liver, holding the liver up, actually scarring it to the abdominal wall. There's cancer-related fluid that we suck out and send to pathology. And you can survey the entire abdomen. So look at all the quadrants, look at the small bowel, and get a sense of how advanced somebody's cancer is. All right, so if you close your eyes, you can open your eyes. The videos and photos are done. All right. It can be very disappointing to find cancer that's spread, but I tell patients it's much better to know the truth about their stage so that they can get the best possible care. And sometimes the staging laparoscopy can open a door to a clinical trial, or sometimes the biopsies that we take can help someone like Dr. Klempner know what chemotherapy he should give to a patient. Other scenarios that we use staging laparoscopy, if you've had a treatment for gastric cancer and there's something funny on the CT scan, sometimes we'll do a staging laparoscopy to further investigate that finding. If you have rising tumor markers in your blood, but nothing on your CAT scan, sometimes we'll do a staging laparoscopy to look with our eyes. Sometimes we use it to monitor response to therapy, and sometimes we use it to try to get people into clinical trials. So I'm very liberal using staging laparoscopy. It's a fairly low risk procedure. I'm happy to use my operating room time on it because I think if the information could help a patient, I'm willing to do it. So I'm just going to move on to some characteristics of high quality surgery in this disease. And I have 4 main buckets that I think of that are characteristics of high quality surgery. The first is margins, second lymph nodes, third complications, and then what I call the nice to have bucket, which is minimally invasive surgery, but I'll go over each. So the goal of a surgery for a cancer is generally to remove the entire tumor from the patient's body. And so in addition to the tumor, we want to take extra tissue around it so that when the pathologist looks under the microscope, they don't see any cancer cells. That's called a R0 resection, if you've heard your team refer to it that way. And I think one of the most important decisions that the surgeon makes is which operation to do. So how much and what part of their stomach or esophagus are they planning to remove? And this should be based on where the tumor is. And this will give you the best chance of getting a negative margin. Another thing that the surgeon can do is they can actually have the pathologist look at the specimen while you're asleep in the operating room and wait. And it can be up to an hour, but I will always do this for my cancer patients, have the pathologist examine that margin and tell me, do they think that I need to take a little bit more? Does it look good? And I think it's worth the wait to get that negative margin. There are situations when the margin can change and sometimes the surgeon can't take anything more, especially on the duodenal margin here. Sometimes you're just limited. But I do think that the goal would be something like 95% of the time getting a negative margin. For lymph nodes, there are national guidelines about how many lymph nodes the surgeon should remove. The minimum is 16. It's required for us to really understand the cancer. And there is some evidence that it might help long-term cancer outcomes. And it's very sad in the United States. Depending on the paper you read, it can be fewer than half of patients getting to this minimum number of lymph node retrieval. So in the United States, we definitely have a lot of work to do to get all gastric cancer patients the appropriate number of lymph nodes removed. The next area is, of course, surgical complications. I really believe that technically meticulous surgery leads to improved outcomes. This is just a diagram of an anastomotic leak. There are things that surgeons can do in the operating room to minimize the chance of any complication, bleeding, infection, leak, pulmonary embolism after surgery. But even the best surgeon will have complications. One of our sayings in surgery is very simple. Surgery is hard. And the reason it's hard is because of the complications. And then finally, I think there are a lot of patients who would benefit from minimally invasive surgery. I try to offer as many patients as possible robotic surgery. This is the robot here. I control it from a kind of a seat a few feet away. But there's some data that minimally invasive gastrectomy has lower blood loss, faster recovery. It certainly has a lower hernia risk in the long term because the incisions are smaller, but it is slower. You get more general anesthesia. It's not available everywhere. It does require special training, and not every patient would be a candidate. But in the United States, I think it's pretty underused. So I have another series of videos and photos. So if you don't want to see it before lunch, close your eyes. Okay. All right. This is a photo I took in the operating room of a lymph node dissection that I did for a patient with gastric cancer. So you can see there's a portion of the stomach missing here. And this is the pancreas, which sits behind the stomach. And the arrow is pointing to the common hepatic artery. And the reason you can see it so well is because we stripped that artery of all of the surrounding lymph nodes. And then there's a gap here where you can actually see the liver. That's the caudate lobe of the liver. And you can see it because there used to be a lot of lymph nodes here that have been removed as part of the specimen. And then this is what a gastric cancer specimen might look like. This black area is where one of my gastroenterology pals tattooed so that I would know that the tumor was over here. And you can see that there's all of this fatty tissue alongside the stomach, and you want there to be at least 2 centimeters of this tissue because this is where the lymph nodes live. And the other thing you'll notice is even though the stomach is cut here, there are lymph nodes that are pulled down from above. And this is another way to ensure that you get those 16 lymph nodes. And then this, probably my favorite video of the slide deck. There are ways that the robot can help the surgeon get those lymph nodes. So another reason I like robotic surgery, other than the lower blood loss and the faster recovery, is it does permit you to do fluorescent guided surgery. So for this patient, I started the operation by actually doing an endoscopy myself and injecting a special dye around the patient's tumor. And this dye would then have time to travel through the stomach wall and through the lymphatics to the lymph nodes. And there's a special button. If I can play it again. There's a special button that I press on the robot and it turns that dye green. And that way I know, okay, all of the green areas need to be included when I take the stomach out. It's really helpful in the United States where obesity is common because sometimes lymph nodes can just look like fat. So this helps me say, no, these are actually lymph nodes. To illustrate margin, I have this photo. Again, this is a tumor that one of my GI colleagues clipped. These little metal clips were left behind by the gastroenterologist. That the tumor is here. And then around the tumor, radially, you see there's all this normal stomach. And the idea is that we have a ton of extra stomach around the tumor so that when the pathologist looks at it in the operating room while the patient's asleep, they can confidently say all of the tumor is gone. This is a picture of someone's abdomen at the end of their robotic gastrectomy. This is their belly button here. We do have to make one of the incisions a few centimeters longer because we have to pull the stomach out somehow. And then this is a year later, and doesn't really look like they have surgery. If you squint, you can see his scar here, but typical open gastrectomy would have a scar that goes from here to here. All right, photos are done if you weren't watching. Okay. All right, so finally wanted to share some thoughts about how to choose the surgeon. And I think it's actually very hard. You know, if you're not a medical person, you can't ask your pals, which surgeon should I go to? Like, how do you pick a surgeon? And I have some ideas for you to consider as you think about who might operate on you or a loved one. And the first area is expertise. So does your surgeon have any kind of specialized training in gastric or GE junction cancer, right? Have they done a fellowship that's relevant? You know, my kind of I don't know, soapbox statement is just because you can take a stomach out doesn't qualify you to treat gastric cancer as a surgeon. You know, has your surgeon done any research on gastric cancer? Do they belong to organizations that are related to gastric cancer, like the International Gastric Cancer Association or Society of Surgical Oncology? And then, of course, you want to make sure that your surgeon is board certified. Experience is a little hard for me as a younger surgeon because I have fewer gray hairs than most of my colleagues. And some people really want a surgeon with gray hairs. But you can ask the surgeon, like, what is your experience with this operation? How many lymph nodes do you plan to remove? Do you do anything to ensure that you get the right lymph node count? How do you ensure a negative margin? And I think these are really fair questions for a surgeon as you consider who would do your cancer surgery. I don't think you can discount the importance of your relationship with the surgeon. I don't believe that a mean surgeon who's good in the operating room is a good surgeon. I think a surgeon should be expected to have all of the skills of a physician. You know, does the surgeon listen to your concerns? Do they take time to answer your questions? Do they make you feel like you're cared for? If you're not comfortable with your surgeon, it's going to be very difficult to have a post-operative complication and be confident that you're getting high quality care. And then finally, there are logistic concerns, you know, even beyond the surgeon. We know there's a lot of research that hospitals where complex surgery is routine take better care of patients who are receiving complex surgery. And gastrectomy, esophagectomy definitely fall into that bucket. And I think it's because hospitals like MGH or other large centers have all of the other services and resources to rescue patients if they have a complication. So having really excellent interventional radiology, really excellent gastroenterology, really excellent radiologists, cardiologists, having all of those services in place helps the patient even beyond how perfect your surgeon might be. And I know that some people like to, you know, travel around the country to find their surgeon. And I think there's pluses and minuses to that. It's hard to have a complication and be 2,000 miles away from your surgeon. Your surgeon can't do much for you in that case. And sometimes it can be hard to coordinate the care if you've traveled, you know, to several states over for your surgery. Another saying we have in surgery is sometimes, you know, frequently surgery is humbling, but sometimes it's humiliating. And that's because all surgeons have complications. Even a perfectly executed operation can result in complications. And even if some complications are rare, they happen to somebody. Fortunately, most complications for gastrectomy and esophagectomy are really well managed, and there have been some great technologies that have come through, like esophageal stents, that really help us take care of people who develop a complication. So I'm just going to end with an English proverb about the 3 qualities of a good surgeon. You know, maybe this will be the one thing you remember from the talk, but I think you'll figure out why I like the saying. So according to this proverb, you know, this is when surgeons and barbers were like the same person. The 3 qualifications are that they have to have the eye of an eagle, the heart of a lion, and the hands of a lady. So happy to take any questions. Yeah.
Oh, thank you. All right. Maybe I'll start asking you. Maybe you could talk a little bit about sort of talking about risk and assessments for like older or more frail patients, I know is something that you spend some time thinking about.
Yeah, so this is a disease that happens more commonly in older people who have other medical conditions related to their heart and lungs. And I think these are really big operations that can also cause big quality of life changes, right? Some of you have already mentioned some of them. Living without your stomach is not easy. And esophagectomy is an even bigger operation. And one thing that I really love about working at a hospital like MGH is we actually have a special clinic called Perioperative Senior Health. And I will frequently send patients to this clinic, and they get a 2-hour evaluation from a geriatrician, head to toe exam, cognitive testing, muscular strength testing. They do a whole social intake. And they actually can tell me and Dr. Klempner, what is likely to happen to this patient over the next few years, forgetting about the gastric cancer. And some of our patients who are so sick, once they hear kind of what their anticipated trajectory would be, realize that they just want to focus on the quality of life that they currently have. They're not interested in being discharged to a rehab facility. They're not interested in the possibility of living in an assisted living facility for any period of time. It's one thing for me to say to a patient that the complications include occasionally death or going to rehab, but they will actually generate a graph with the number estimates. And sometimes just seeing the hard numbers can be helpful for somebody. And we have other ways of treating people. So sometimes we'll ask our radiation oncologist to see somebody and use a different local therapy other than surgery. And what I tell people is I'm not here to bully you into surgery. Nobody can force you to have an operation. We can tell you what the risks and benefits are, but it's a decision that we make as a team, what makes sense for your values.
Yeah, it's a pretty cool clinic. I wish it was just totally standardized, but we have a couple minutes for, yeah.
Give me if this question is like just geared towards me, but I had an esophagectomy 8 weeks ago, and I'm dealing with, I've had, I think 4 or 5 dilations because my food is still getting stuck. So my surgeon, he seems, I really like him. He says it's very normal for this, as far as a complication goes. And I guess my question is how many of those can I expect before my esophagus stays open so I can eat?
Yeah. So stricture, definitely common complication. The idea is that when we sew 2 pieces of bowel together, the way it heals together is it scars together, basically. And sometimes it scars so much that it narrows. And so the dilation is about stretching that scar tissue. Most of the time, the dilations will be effective. You're actually very close to your surgery date. I would still consider you in the kind of acute postoperative period at this point. But there are kind of 3 things that could happen. One is that at some point you stop needing the dilations, which would be the best possible outcome. Sometimes patients need intermittent dilations, like instead of doing it 4 times in 8 weeks, they'll say, okay, every 4 or 5 months I need to get dilated. And then you kind of can tell when you need it again. And then rarely, and this is rare, the surgeon might actually offer a revision of the anastomosis, but that is a very rare circumstance. So, but not 0.
Thank you.
Question. What is the reason for lack of significant lymph node resection? It's interesting because in breast, it's the opposite problem. Is it that there is a lack of fluoroscopy capabilities in the community? And second question, what's the typical window you mark as highest complications post-op? What's that critical window post-op where you see most of them. And I was curious about whether these gastrectomies are typically performed in community settings and what might be the level of training, expertise, and available technology.
Yeah.
Is the lack of robotics outside of academic hospitals because of availability and cost?
Yeah, I actually think the community hospitals have embraced robotics maybe earlier than a lot of the academic settings, to be honest. So there are a lot of great kind of non-academic community surgical oncologists or general surgeons who invested in learning robotic skills many years before academic surgeons. So I don't know if I should be like proud or embarrassed that I started the robotic gastric program at MGH 2 years ago. That's kind of late, I would say. And the reason that the lymph node dissection is hard in gastric cancer is it's actually much easier to do the surgery if you just stay close to the stomach. Once you start coming out here, there's other organs over here, like the spleen and the liver. And this blood vessel here, the common hepatic artery, is the primary blood supply to the liver. So the stress of stripping this blood supply of lymph nodes is much higher than just leaving those lymph nodes behind. So there is definitely a technical skill component to it. I would say that my greatest strength as a surgeon is that I'm patient. I have colleagues who want to get as many operations done in a day as possible, and this takes a lot of time. So again, I think that's why having a surgeon who really cares about gastric cancer and having good gastric cancer outcomes is important. The robotics piece, I do think, there's some paper from like 10 years ago that looked at how much surgical oncology care is provided by surgical oncologists versus general surgeons in the United States. And it's something like 85% of surgical oncology care in the United States is provided by general surgeons and not fellowship trained surgical oncologists. So, if you're doing one gastrectomy every other year, and you don't spend every Wednesday afternoon at 12 o'clock thinking about this disease, you may not be as aware of how important it is to get those lymph nodes. Yeah.
Yeah, I think, well, some of you I see in clinic, and so I think you may have heard us say, like, there's a lot of people that can give chemo, like as good as we can give chemo, but you definitely want to come to a high volume center with expertise for your surgery. You only get one shot at surgery, where we can always move chemo place to place if we really need to. Probably have time for, yes, one more question.
So I know that some centers here in US, they do HIPEC surgery for peritoneal cancer. And even in some part of the world, they do the PIPEC. So what's your opinion regarding this treatment?
Yeah. So great question. So peritoneal recurrence is definitely a huge problem in gastric cancer. And for many patients, that's the only place that the cancer goes, and it's very difficult to treat. My recommendation to a patient, if they came to me and they were interested in that therapy, is I would encourage them to only receive it in the setting of a clinical trial, so that we can learn about it as much as possible and understand whether it's effective or not. There have been some research papers looking at this that have come out in the last year, and this is actually a reason that I will do staging laparoscopy for some patients, is to see if they are eligible for a HIPEC clinical trial. But I think that it's a controversial area in gastric cancer. It's certainly not standard of care, I would say, where we offer it to every single person who has peritoneal disease. And I think you've heard about a lot of the challenges in gastric cancer. It's not a common cancer in the United States or North America. And as many patients as we can get to participate in clinical trials to learn if HIPEC or PIPEC should be part of the standard of care would be really helpful for the whole community. Yeah.
from a oncologist standpoint, we would love to have more data for this question. Comes up all the time. It's also really hard to do peritoneal trials. To be honest, a lot of the companies are not so interested in like putting Taxol into the abdomen because Taxol is like a generic drug. So finding ways to convince people it's important and maybe do some of our like novel or newer drugs into the peritoneum. Like there's even some studies of putting like CAR T cells right into the abdomen, and like that might be part of the path forward, not just putting the same chemo that's may or may not be working for the patient when it's given in the vein and expecting it to all of a sudden magically work if we put it in the belly. But I totally agree. In a clinical trial situation, ideally, yeah, you can have the last. I know Dan Von Hoff. I think he's very famous oncologist. For those that don't know him, did a lot of pancreas cancer work in his career. And yes, I think there's a lot of people who recognize the importance and understand it, but it's one thing from having a good argument and rationale to having a business case for a company to say this is why you need to do this. It's hard. We all want to do it. I think on that note, it is pretty much exactly noon. We have lunch for like 20, 30 minutes. Then we'll hear actually we've been talking at you guys, many of you are patients, and now we're going to hear actually from patients from around 12:30ish, maybe a little bit before that. Got about better part of an hour to hear from actual patients. So enjoy a little bit of food, and then we'll meet back here in like 20 minutes.
Hi, everyone. As you are walking out to lunch, I just wanted to say hi. I'm Sarah. I work in the development office at Mass General. We're so happy to have all of you here and have Debbie's Dream here. I just wanted to give you info about parking. So if you parked on campus today, we will cover your parking. So make sure you get a sticker. You can go to the registration table if you haven't. When you leave, you need to talk to a person before you get in your car. I wish the system was different, but you can go to one of two parking offices. One is in the lobby of 165. So when you leave, just go to the left, that building in the lobby, talk to that person, or go across the parking lot, go downstairs by where Flower is, go walk into the parking garage, and there's an office there. I know that's a little bit convoluted. I apologize, but we're happy that you won't have to pay for parking. If you have questions, just let me know. Thanks so much and have a good lunch.
Perfect. Thank you very much. So I'm going to go right down the row, let everybody introduce themselves, share as much as you want, but maybe start at the point where when did you know something was wrong?
Okay. My name is Shimon Milisak. I'm a 44-year-old male from Pennsylvania. And things kind of started with me, I'd say probably I was diagnosed, I'd say around February 2022. Well, my original diagnosis should have been 2021. So in 2022, they found it, but they also looked back at some paperwork once I went in for diagnostics and found out that when I did go in originally, my cancer was found at that point in time. I just wasn't told. So I sat with the cancer for a year before anything happened, unfortunately. But around 41 years old, I was just in this arena where I just started feeling a little stagnant. I wasn't having any type of irritable bowel syndrome or anything along those lines, but I was having a change in my life, and I got into the gym and was working out and becoming very healthy. And I decided at 41 years old to play semi-pro football. And from playing football, I ended up taking a hit to the abdomen, which for whatever reason caused me to have black stool. And when I had the black stool, I went in and they saw that and did a endoscopy, and it turned out that I had H. pylori. From that point, I looked up black stool and H. pylori, and in my head, I knew that I had cancer. I just could tell by how I was starting to feel. I had just met my caretaker at that point in time, Melissa, who's here, and we spoke about it ad nauseum, and she would say things like, don't speak it into an existence and all those things. But what ended up happening is they treated me for H. pylori, told me that an ulcer from the H. pylori is the reason why I had the black stool. And they assured me that nothing else needed to be done and that I was good, all the way to the point where the endoscopy center gave me a cease and dismiss letter because I kept going back and saying, I want you guys to do something else. Like, something's not right. I'm still not feeling well. So really basically what happens is I start firefighting, coaching high school football, and about a year later, all of a sudden, it was actually one of my first fires, a brush fire, and it was just myself and my chief on that call, and I over exaggerated myself that day, and when I was relieved off the fire hose, my chief came up to me and everything was just kind of blurry, looked yellow. I ended up going to the hospital that night. The following Monday, I got an endoscopy done and they told me I had cancer. So,
yeah, no, it's always humbling and a little bit upsetting to hear the origin story sometimes. We'll definitely come back because I know there's a lot more to your story over the coming years. But yes, Allison, feel free to introduce yourself.
Yeah. So my name is Allison Coley-Ellsworth. I was 44 when I got diagnosed with stage 4 stomach cancer that had spread to my peritoneum. And I found it just by having heartburn and acid indigestion, and that's the only symptom I had. I think from when I started having it back in, it was like September of 23, I think my stomach hurt maybe twice, and that was it. And I kept going back to my doctor, and I could never, for those of you that try to get with your doctor, and they're always so packed, and you can only get in to see the nurse practitioner, that's what happened to me. And I kept going back and back, and they would tell me, oh, it could be COVID. Oh, it could be because you're eating tomatoes or bananas or pineapple. Like, if food bothers you, stop eating it. And I was popping Prilosec like it was candy. And I finally had my physical in, it was like the beginning of February 2024. And that's when I complained again about it. And she said, well, let's just do a CT scan. And fortunately, when I went in, there was going to be that was on Thursday, and there was going to be a snowstorm the following day. So everyone had canceled their CT scan appointments. So I'm fortunate where I live in Foxborough, and there's the facility right there. So I got an appointment the next day because everyone canceled. And she called me like 3 days later, and that's when she told me. And it was like, I am healthy. I do all the right things. Like, how could I have ended up with this? And do you want me to go into I'll briefly do it. I started off at a different hospital and was told, chemo's only going to buy you time. And I went through the system very fast. Like, from when the CT scan results came back to when I actually started chemo was like not even a month. So they got me through very, very fast. And my first oncologist said, chemo's only going to buy you time. You'll never be a candidate for surgery. And I knew that wasn't going to be my story. So I was very fortunate to land in Sam's office like 2 weeks later, and talk to me about different options that I'm sure we'll get to in a little bit. But had great results and was able to have my stomach removed that following November. And now I'm just on my road to recovery.
Yes, we'll definitely get more into your story as well. I know you guys have some similarities, but Tom, sort of tell us your origin.
So my origin story started probably 15 years ago with uncontrolled reflux. I probably went 10 years poorly managing it with Tums, and my family has a history of Barrett's esophagus, which is a change in the lining of the esophagus. The cells start to look a little bit more like stomach cells. It's precancerous. And so I thought I should probably go get an endoscopy. Went and got an endoscopy, was diagnosed with Barrett's. And you typically get surveyed every year or two with another endoscopy. And I did that for a few years. And then just 1 year, they said, we have some bad news. You have cancer. And so that started me on a treatment. I guess we can talk about it later. That was with BIDMC, which was the hospital where I had the endoscopies. But then kind of like Dr. McKinley was talking about, I shopped around for a doctor and ended up at MGH, which I'm thankful for because that put me under the care of Sam. And I'm eternally grateful for that. But that was 5+ years ago. So I've been serial negative on CT scans and in a trial that Sam ran. So I don't think my cancer is going to come back, but neither is my esophagus. So
Yeah, that's true. We'll definitely come back to you because you were sort of willing to participate in sort of research about additional monitoring beyond sort of standard imaging. But maybe I'll start with you, Jamal, about sort of what was it like let's talk a little bit about your recurrence and then sort of how you wound up on a clinical trial, maybe.
Yeah, so shortly after all that happened, I went through the process, stomach taken out. I was told in the beginning that everything was clear. They found everything, took everything out, and I was good. And then my stomach came back from pathology, and they had seen that it went through all 4 layers of my stomach, and that it was in my peritoneal. So stage 4, they gave me 12 months at that point in time, and just like Allison, like I just knew that wasn't my story. So that organization or hospital became very disinterested in me at that point in time. So I searched around. I went to MSK, NIH. I went out to Fred Hutch in Seattle. I ended up down in MD Anderson, going down there every 3 months for surveillance. And for about 3 years, it was NED, no evidence disease, no evidence disease. I was living my life, advocating hard, and just trying to help others in this realm. I feel that there's just a certain way that you should live with cancer to not let cancer win. But that's what I was doing. And about, say, 9 weeks ago, I went through a series of bowel blockages, so many surgeries. I think I had 5 surgeries in a 6-month span at the end of last year, just from bowel blockage. And every bowel blockage, they took biopsies. Those biopsies all came back negative for anything. They knew that I was, had the signet ring cell, and they couldn't find anything. And then finally, the last bowel blockage that I had, they said it was because of scar tissue. So they went in to clean up the scar tissue. It was a 7-hour surgery, and I came out of that surgery and instead was told that he had to do a resection, and he had sent that bowel away to get tested. And then he reached down into my peritoneal and found some polyps that he sent away. Then we found out all those came back cancerous, positive for signet ring cell. I went through a downward spiral. All the advocacy that I knew, all of that just went out the window. I was just, after all that time of NED and you're good, it just was I just lost it. I was lost for a little bit, and then advocacy came after me. Some of the gals in my organization or our organization grabbed onto me and they said, "You need to go see Sam." And I think I contacted Sam on like a Sunday or around midnight. One of the gals actually spoke to him and he said, "Have him contact me." And I contacted him on a Sunday, and I was in his office that Thursday. So I was open for anything and everything, and so here I am in the trial.
Yes, no, but nobody's being paid for this. Please feel free to be honest. Yeah, we'll come back to talking about sort of the importance of community, because obviously that's a lot about what this is. But maybe Allison, because you saw a few of our research team is here, so talk a little bit what it's like to go on a clinical trial. Some people are wicked scared of clinical trials. They're like, I don't know what I'm going to get. What were your biggest fears? Anything you want to talk about sort of like being approached for a trial?
Yeah. I think, first of all, I knew nothing about clinical trials. I really knew nothing about cancer or getting diagnosed or anything when I was diagnosed. So when I was first given that news, you're going to be standard of care, I knew that I was not a standard of care person. In my head, I was just like, I am not standard of care. So when I walked into Sam's office and, he said, here's what standard of care is and what you're going to be offered. And here are your 3 other options if you come to MGH. And after having them all kind of described, I kind of put him on the hot seat and I was like, well, if you were me, what would you do? And he's like, door number 3. And I was like, well, door number 3 it is. But I think that, again, I knew that I wasn't going to be a standard of care, and I knew that no clinical trial or anything that I was going to go on was going to be a guarantee. But I also knew in my heart that it wasn't going to hurt me, and it was going to offer me the opportunity, or could offer me the opportunity, to so much more. So why would I shut the door on that? And after he went through and explains the difference between, that there were other drugs out there that were doing similar things to what the trial drug that I was going to be going on was already doing, it were already approved, and this was kind of like the new upgraded version of it, I knew that that could give me a bigger chance. And it was at a targeted immunotherapy, and I tested very, very high for the target. So I was a really good candidate for that just because of the amount of the target that I had. So for me, I just thought, I don't want to be standard of care. Like, I want to have this. I know it's going to suck and be hard for X amount of months, but that's what I want to do because I want to be on the other side of this. And like Jamal said, not think about it. And obviously, once you've had it, it's always going to be in the back of your mind. But I knew the clinical trial in my heart was going to give me more of that opportunity. So once he presented it and talked about, the results that were already being shown, it was a no-brainer for me to do it.
And did you do anything like behind closed doors? Like we give you that consent and then you like show it to some friends, or I'm just curious.
Okay,
You don't have to answer.
I actually didn't because, and he did not pay me for this at all, what I'm about to say. But the first set of oncologists I talked to were so anti like being on my team. And I was an athlete my entire life. So I wanted a physician to be on my team, to be like, okay, this is what you have. This is what the stats are. But I know your goal and I'm going to help you get there. I can't guarantee that you're going to get there, but I'm going to help you get there. And that's the way I felt when you sat down that day. So when I literally asked, like, what would you do? I was going to go with whatever you said because I immediately trusted and I knew that you had my back as a part of my team. So, and I think that's the way my care has kind of always been, is deferring back. So I honestly, that was the one thing I didn't Dr. Google. I'm bad. I Dr. Googled everything in the beginning, but I didn't look at that. And I really didn't look at the results of it. I remember I would always say like, all right, what's my goal for my next scan? Even though I didn't understand what that meant, I needed mentally a goal because that's what I was going to shoot for. Even though I knew for myself, I didn't have that much control over it and that my treatment was going to control it. But in my head, I had to know what the goal was. So that was the only thing I kind of thought about was, all right, what is my goal to the next thing? And I put all of my trust in your suggestions and in the drug, honestly.
Spoken like a runner, just look at that next one more lap, next pole to run to, whatever.
Right. I knew what my big goal was, even though I didn't fully understand what surgery meant. Once I was told no, that became my goal. So I was like, all right, I need little chunks of a goal to then achieve the big goal. So that's just how I looked at it.
Yeah, no, I think breaking things down into like something that's palatable or tangible is definitely important. Tom, I want you to talk a little bit about whether sort of doing this additional monitoring, in this case, it was circulating tumor DNA to try to like look for residual disease after surgery, just so everybody knows what we're talking about. Like knowing that this might find something, but that we don't really have anything to do about it, is that like a anxiety provoking thing, or like how do you sort of get comfortable with that idea?
Actually, it's kind of the first time I thought about it, so I'm glad I didn't think about it earlier. So yeah, just add on to that. So the study was looking for fragments of my cancer still circulating in my bloodstream after my surgery. And this kind of complements the CT scans, which are also looking, for the cancer. I think in the end, it has given me so much more confidence in being able to live my life, right? So I realized that radiology isn't perfect, and neither is endoscopies, and the sensitivity of this study, when we finally said at 5 years, there's no sign. I mean, now I actually felt like I could, take my eye off the ball. And it's been helpful for me in that way. I think where I understand the research is going, and I think is even more important, is informing the decision of whether or not your esophagus or stomach needs to get removed. Because, you know, the cross protocol, which I had, is actually a very mild chemo and radiation compared to probably what some of you have had. It's not that bad, but the removal of your esophagus and pulling your stomach up through your diaphragm, and it's life-changing. And you research, I mean, this is kind of my pitch for where research should go. Any research that informs whether or not you need these drastic surgeries, I think is valuable.
Yeah, totally. We have experts we'll hear from a little bit later doing some work on this. So yeah, huge need for the field. I think we hear it loud and clear that anything we can do to further identify people who might be able to get away with close monitoring instead of surgery. Obviously, we need to work and look into that. It's critical. Jamal, I want you mentioned community, so maybe talk a little bit about how the broader stomach cancer community has helped you, or what you've gotten from them, or what you've given to them. And then maybe if you also don't mind touching on, like, you know, when people are on clinical trials, they often get like a bunch of other people on their team that aren't on a normal standard of care team, like research nursing, clinical research coordinators, you know, additional infusion nurses in special areas of the hospital sometimes. So talk first about sort of the broad importance of community and how it helped you. And then if you don't mind talking a little bit about, like, is it nice to have a bigger team?
Yes. For sure. I think that if someone were to ask me, what's one of the most important things that you picked up or encountered to help you fight cancer, it would have been the advocacy group. And like, it's so weird. The people that I thought that if something like this happened to me in my life, whether it was like my house burning down or whatever, the people that you expect to be the ones that are going to be there, for the most part, that's not what it looks like. I have a new family. I have a new structure around me. I've learned so much, and from two different advocacy groups, and as a whole, it's all the same. It's just beautiful people that understand what's going on in certain ways, and care in the way that you need them to care for you, or even for you to care for them at times, to help you feel like you have some type of power and that cancer is not beating you up as well. It's been monumental through my whole entire existence of living with this disease. And then even for the second half, now that I'm in this clinical trial and I do have the large team, for the first time I'm fighting cancer and not having to worry about more than I need to worry about. Like, there's a comfort there that I won't fall through the cracks, because there's somebody there that has some type of expertise in almost every section. I'm talked about. They follow my transportation to and from, if I'm going to be okay in that aspect, all the way down to making sure when I'm getting the infusions that I'm nourished, and if what they're serving is not what I want, they make sure there's something there for me. It's just all the way around. You just feel cared for in a different way. It's been very good for me.
Even though like 10 people ask you the same questions, like the research nurse, then the fellow or resident, then probably me ask you the same question. What was I going to say? Oh, Allison, I want you to talk a little bit about like things you wish you knew, or like things that you would tell someone else. Could be anything.
Could be anything. Oh, it's like a loaded question. Well, I think the first thing is, in any case, just being your biggest advocate. That, you know, some people have already touched upon it before, like, you can keep going out and getting different answers, because sometimes you will get different answers, and sometimes you're going to like them and sometimes you're going to hate them, but don't stop until you're given the answer that is comforting for you and that you're comfortable and confident with. If I honestly had to be forced to get a second opinion, because I didn't think second opinions were going to be different from the first, to be honest with you. And I'm so fortunate, just like, you know, the other two gentlemen sitting next to me, that we ended up in Sam's office. And there's not a day that goes by that I'm not so blessed for that. but just being your biggest advocate, I think, is the first thing. And two, just listening to your body. Like, you know your body better than anybody else does. So if something is wrong, speak up. I wish I was like more forceful in the beginning, and listening to your body. If you do go through a major, like, once you have cancer, your life changes forever regardless, right? Just like Tom was saying, it's always kind of in the back of your head and you're always thinking about it. But know your body and listen to it, and give yourself that grace to recover and to heal, because that's such an important part that I really had to force myself to listen to, because I'm like type A, 100 miles an hour all the time. So when I would sit, on the couch for like 2 days and do nothing, that like probably mentally broke me down, but I knew that's what I needed to do. So through any process of being sick, just give yourself grace and listen to yourself, listen to your body.
Yeah, I think very, very good advice. This like setup reminds me of like a 90s talk show. I feel like I should like, and this is your long lost brother. But Tom, I want you to talk about a little bit like when we talk about surgery, we tell patients, to the best of what we think, we're doing a good job of explaining like the risks and what's it's going to be like after surgery, but clearly we're not actually that good at communicating that. And you heard a lot about it in the morning, but what are areas that we could be better about talking about things like surgery? Like, we don't want to beat people over the head, but at the same time, we want to be like transparent that this is probably going to change your life. It's like, where could we be better?
Well, it's interesting. When I first got talked to a surgeon at BIDMC, before I started my chemo radiation, he said, let's not even talk about the surgery, because you don't want to know about it and you don't want to know what it's going to be like. Just get through the chemo rad first. And actually that was okay. I mean, I really had to have my esophagus removed, so it kind of didn't matter what it was going to be like. I'm not sure there's that much more that the doctors can do in terms of prepping you, except for maybe to connect you, with the rest of the community and patients with the lived experience, especially in your type of surgery or cancer. So, we heard from nutritionists and doctors, and they'll give you a lot of good advice and pamphlets going out of the surgery. But talking to people who actually have to figure out, like we were talking last night about when you start to get hypoglycemia, how many hours after you start to get that, do you take a sugar tablet? There are people that have the same, exact surgery that are maybe a year or two ahead of you and can give really, really good advice. So I think what the hospitals can do is help connect you to, sometimes I serve as kind of an informal mentor for people that are just getting my surgery. But also to groups like I'm on Smart Patients, which I'm not sure if anybody uses. Fantastic. You can post a question, and the next morning, 5 people with your exact same condition will give you their answers. And it's that kind of pairing you up so you can get the really lived experience, I think, and lived advice is helpful.
Actually, that's the first time I've ever heard of Smart Patients.
Oh my God, it's amazing. All different kinds of cancers, and a lot of support there, like emotional support. Sometimes it can get a little bit dark for the people that are terminal, but I'm having trouble because I have this reaction to this kind of food. Oh, mix it with this, and you'll be able to digest it better. Or, oh, I'm getting reflux at 2 a.m. Why is it? And there are people that, again, are a couple years ahead of you that found the solutions and are on the message board every day. So they've seen a lot of other people's answers to it. It's just a great resource.
Yeah, I'll have to check that out. If you see like some funny username, maybe I'm impersonating patient.
Yeah, it's got to be patients only.
Yeah. Oh, cool. That's good to know. I don't want to get dark, but a lot of patients are diagnosed with advanced disease with this cancer. By the time they find out about it, it's spread to other places. So, Jamal, if you're comfortable, and then I'll ask Allison a similar question. Do you like to periodically hear the numbers and the statistics, or like you heard it once, you don't need to be reminded of it? Like, how do you think patients like to hear this kind of news?
thing that's hard for me, I'm definitely, I'm driven by my faith for sure. So I think for me that part doesn't matter, and I think that helps me. That has helped me along the way. When they gave me 12 months, I just said, "All right, you're not for me. I'm going somewhere else." And so I don't know. For me, I don't know if that's a easy question for me just to grasp onto, because I like to hear the numbers. I do hear the statistics, but then for me, the competitiveness comes in. The football player and coach in me and the military side of me, and I just want to beat that, and that's it. And not just for myself, but for others, to show others, like, don't listen to that. There's one thing that I always try to tell everyone, is that we're all totally individualized, and it's life. It's a momentum. There's something that's going, and there's a lot and sometimes a little that stops those things, and no one knows when it's going to be. I mean, I could be in a car accident on the way out of here, and that's cancer never is the reason why I go. So I just choose to just keep living. Just keep living.
That's a very good answer. I'm going to ask you, Allison, same question if you're comfortable. Like, obviously, we have to tell people some sense of the numbers, where we can't predict for an individual patient, of course, but how should we hear that? How should we communicate that?
I think the way that you communicated it was great. I think it's helpful to know the numbers as much as maybe you don't want to hear the numbers when they seem like they're not in your favor. But I looked at it a little bit differently when it was like, okay, here's the survival rate, and I think what was actually really, really helpful was when you actually went through and explained like who's actually included on those statistics, because different things can change it. And personally, I don't think that the way they do it is actually giving it a fair statistic. Like, I feel like the number probably isn't really fair. I think it's very skewed. So when you told me the rates and then went through and explained it, then it became like, all right, well, I'm going to then my goal was to help that number change and go up. So I kind of looked at it again, just like as a competition. Like, that's in my, I can't help it. I mean, in my head, that's kind of how I looked at it. And, I just looked at it like, all right, this is just something else to beat, something else to fight, and then to the community question, like, I really believe like that was helpful for me. Like, when I was a little athlete, my dad would always say, surround yourself around the people who are doing what you're doing or where you want to be. So I would, on all the Debbie's Dream and other pages, I would just go out and I'd find people that had success and that were older than me. And I'm like, okay, damn, if this girl can do it at 56 and she's 6 weeks out and she's rock climbing, I can do that too. So that's where community came for me. So I looked at the statistic more of as like a competition, and then surrounded myself around those people that were already crushing it. And that for me worked.
Yeah, no, I haven't heard it described the same competitive way, but I like it. I'll remember that. Tom, you're like a number cruncher data person. So your situation is obviously a little bit different, but it's still a calculated risk to take a surgery. Or did you find the data like useful in granular sense, or sort of broad strokes was okay?
Yeah, I think I really wanted to know the numbers as well. And roughly speaking, for the whole population, again, this isn't kind of segmenting it enough to really define me and my case, but it's 50% chance of survival if you have the surgery, 25% chance of survival if you don't. And yeah, I needed to know those numbers. And then, like you were saying, Allison, I want to do everything I could to improve my chance at those numbers. I actually have a friend who has terminal brain cancer, but he's doing the same thing. It's just, what can I do to try to help moving my chances a little bit higher? And I can't even remember the question you asked exactly, but yeah, I needed to know the numbers, and it was frustrating not to be able to know, okay, for a 50-year-old male who's been active and doesn't have any of the risk factors, blah, blah, blah. Now what's my chance of survival? And there just isn't that kind of data.
Yeah, no, it's we would love to be able to, give people that kind of predictions. And I do not recommend, going to Chat GPT and being like 50-year-old male. Maybe Jamal, talk a little bit about sort of things, unexpected effects, cancer or the treatment, like outside, what is things that are hard? Like it impacts your ability to work, it impacts your ability to do other stuff that you used to enjoy that you can't do as easily now. Like outside of just the actual treatment, like where does it impact your life the most?
I would say probably physically, just as far as not knowing what's going to happen without having a stomach and like the hyperglycemia. And so it takes away a lot of things, the driving aspects of things, family vacations, regardless of wherever you're at or what you're doing, you have to prepare. We've missed church and things like that simply because we're halfway to church and like, oh, we don't have dad's medication, we don't have his bag with us, or it's just the small fine-tuned things that you have to make sure you have those things in place in order to operate with cancer. And it's one of the things that I can't stand about it. It's competitive with me. Like I in our house we've talked about it ad nauseum that we don't acknowledge it, we don't own it, but it just has its way of always popping up and making sure that it's intertwined in your birthday and your nap time and your whatever it is that you're doing. The cancer has a way of saying, hey buddy, here I am. And I can't stand that about it. So.
Actually, Sam, if you don't mind, one of the things that I noticed about having a GI cancer is that you end up thinking really about every bite of food that you take, and you do that 3, 6, 10 times a day. So you're reminded of your cancer all day, every day, even when you're supposedly cured. You kind of can't get away from it.
Yeah. What about the same question, Allison?
Yeah,
Like,
same. I mean, I feel like when I'm leaving for the day, I'm packing I used to pack my boys when they were like 2, 3, and 4. Like there's just bags of snack. I got to think about like my water bottle being with me, just like little things that, I wasn't going to tell Sam this, but I lost 2 pounds in the last couple of days. And it's because when I'm not busy, that's all I can think about, or all I do think about is food. It's like a part-time job. Like, what am I eating again? When's my next meal? When's my snack? What's my water? What's this? And I've been busy the last couple of days, and just not focusing on it for 2 days, you just drop 2 pounds. So I think that's one of the hardest things, is just like the gentleman said, like you may not have your cancer anymore, but it's always with you, and you're always thinking about, your daily life has completely been adjusted. So yeah, I feel like I'm packing for an infant child, but that child is me.
I have a survey question for all of you. So after your surgery, when you're in the hospital, did you watch cooking shows on the TV in the hospital? Because every time I go in and I see people of mine in the hospital, they seem to always have cooking shows on, and I don't know why, after having a stomach or esophagus surgery. So did you watch?
I did not. I brought my iPad, so maybe that's why. I think I only turned it on for like football, and that was it.
Probably same answer. I did not.
Surprising. I don't know.
Maybe we should have. Maybe that's what we missed.
I don't know. It seems common. So we have a few minutes left in this panel, and I want to give you guys opportunity to say whatever you want, to share to the community here, people online, anything you want to say about your journey. So I'll start with you, Jamal.
I just think that first off, I think everyone should, if you become diagnosed with cancer or anything that's life-changing like this, I would say look for a higher being, whatever that is, what that means to anyone else. I know what that means to me, but that beyond anything has allowed me to have just the biggest escape. The number one thing that when I had peace with all this was truly gaining that peace of knowing the mortality and all that's there. But every day that you fight against trying to stay on this earth or to not get to that point, it's killing you every day by doing that. Take advantage of every moment. You're still living. Be intentional, love on who you can, and love on the people that are loving you. Don't chase the things that don't matter, and just try to continue to stay in your happy place.
Very good answer, Allison. Same thing. Open floor is yours.
I would say when you first get diagnosed or if a loved one does, like encourage them to have all the emotions, like to be angry, to be sad, to be, fearful, like everything. And get them out, because if you hold them in, it's just gonna make it way, way worse. So give yourself that time to have every emotion, no matter what. Like I always say, mine was in the shower where I would just like lose it. But then like I knew like once that water was off, like, all right, get it together. Like you have work to be done. And your mindset sometimes is your most valuable resource. That what you put in your mind and what you say to yourself that you can do it. And I think that's what helped me get through the really bad times, was a positive outlook on it and just a mindset of knowing like, again, this is going to suck and it's going to be hard, but this too shall pass and tomorrow will get better. Even if tomorrow's not better, you just keep saying tomorrow it'll get better.
Tom, same.
Yeah, I'd say in the days or weeks after your treatment or surgery, for me at least, I found the community just being key. And I guess that's kind of my version of the higher being, but it really is a club, like a cancer club. And, we're all here for GI cancers, but I'm going to leave from here and go see somebody, MGH, who's getting out tomorrow after being here for a year. And, we're all with a different kind of cancer. And I think being able to be around other people who are going through or have gone through the same thing is really helpful, because as much as I love my friends and family who haven't gone through it, I don't think they totally understand. So try to reach out and find other people that can understand what you're going through.
Yeah, great. Maybe I'll give the floor to anyone who wants to ask other patients a question, and then we'll get going to the afternoon. And if not, we can transition. Well, thank you. Yeah, Jamal, go ahead.
All right, so this was given to me at one point in time at a firefighter banquet, and it's something that I go by. It's 6 little stories with lots of meaning. Number 1, once all villagers decided to pray for rain, on the day of prayer, all the people gathered, but only one boy came with an umbrella. That is faith. When you throw babies in the air, they laugh because they know you'll catch them. That is trust. Every night we go to bed without any assurance of being alive the next morning, but still we set the alarms to wake up. That is hope. We plan big things for tomorrow in spite of zero knowledge of the future. That is confidence. We see the world suffering, but still we get married and have children. That is love. On an old man's shirt was written a sentence. I am not 80 years old. I am sweet 16 with 64 years of experience. That is attitude. So have a happy day and live your life like these 6 stories. And remember, good friends are the rare jewels of life, difficult to find and impossible to replace. So that's faith, trust, hope, confidence, love, and attitude. And those are my building blocks that I use. So thank you.
I definitely cannot close any better than that. So I will move us to the last part of today, which is really going to be talking about new treatments for people with stage 2 and 3 cancers, people who are going to probably undergo surgery, and how we can make that better and hopefully cure more people. And then new treatments for the people who are stage 4. And how we're sort of making our way through that. So happen to have 2 people here who actually have done a lot of this work and led this. Most notably, my good friend, Dr. Janjigian, came up from New York to talk about a lot of her work. And then we'll hear from Dr. Cleary over at Dana-Farber to talk about some of his work. So despite what they say on the radio and TV, like we actually do have friends at Dana-Farber and talk to them. But the floor will be yours, Yelena.
For sharing these incredible journeys, and each story reminds us that we need to continue to innovate and change approaches for each individual patient. and meet them where they are. And I think this team approach is very important. So I'm a medical oncologist, and we are focused in my practice in gastric and gastroesophageal cancer. And I was hesitant to actually bring any slides, but I would like to make this as interactive as possible. I think I only have about 20 minutes. So by focusing on the most important progresses in the last maybe year or so, we'll just use this as a backdrop, and feel free to ask questions or interrupt. So when patients present with early stage disease, the goal is really to try to improve quality of life and cure and help prevent cancer from coming back. And our definition of early stage disease has evolved over time. And what we really look at when the patient comes in is on the extent of the cancer that we see, and also what we know about the biology and the experience with this disease based on the micrometastatic disease that we don't see. Areas in the peritoneum, as was discussed, but also in the bloodstream, where the cancer has a propensity to travel through, even for as early as really stage 1B or stage 2 cancers. We know that this cancer, its biology, its behavior, just like every one of us in the room has their own sort of, personality. We know the personality of this cancer, our gastroesophageal cancers, is that it likes to sort of set up shop in the bloodstream early on. And so when we look at some of the strategies in early stage disease, what we've done is try to give patients as much as aggressive treatment, systemic treatment, to reduce this disease burden in the bloodstream, but also give the time as a variable in the understanding how the cancer will behave, so that we don't take the surgery off the table for sure, but also we don't rush into the operation, because we know that in some patients, if you take them to surgery too soon, the disease biology will sort of prevent us from curing them, right? So we need to do more, control this system-wide problem early on. And so this treatment, has really evolved to use both chemotherapy and immunotherapy, because we know immunotherapy obviously works in metastatic disease, and it has changed the way patients think about even really advanced disease. I mean, we just submitted 5-year follow-up from our Checkmate 649 study, which, as you know, got nivolumab on the market in the United States for metastatic disease. And it's really amazing to see 5-year survival rates. And this is a global study for patients who were treated not just at tertiary cancer centers like this one or ours at Memorial Sloan Kettering, but all over the world, in middle of nowhere Brazil, or in Georgia, the country Georgia, not the state, but to be able to tell people you can live with this disease, even if it's metastatic, is really transformative. And so now we're bringing it to early stage. And this was the first study that tried to bring it to early stage. They selected patients after chemoradiation, very high risk for recurrence patients, meaning that you have persistent disease left in your tumor sample that they removed at the time of surgery, despite quote unquote aggressive therapy, which wasn't that aggressive, but it was the aggressive therapy at the time, which is chemo, radiation, and then surgery. And in this case, this is a study that us, as US patients and caregivers, but also doctors, don't like to see, which is a placebo-controlled study, meaning that some patients got nothing, basically, in adjuvant setting, because there was no standard treatment at that point, which was nivolumab, anti-PD-1 therapy alone, or placebo in patients who had chemoradiation and surgery. And what you see here, and again, for those of you who are new to clinical trial sort of terminology, randomization of 2-to-1, meaning that twice as many patients will go on the experimental arm versus placebo arm, is something this study employed to try to motivate some patients to go on the study. And as you see here, you want to look at the survival curves with a grain of salt. As we talked about, these don't necessarily translate to each individual patient. This is a population of patients who are treated across different centers with variability. Squamous cell cancers were included, adenocarcinomas, and so forth. But what we look at early as oncologists is at how early do the survival curves separate, and is the survival curve separation sustained? Meaning that we don't want survival curves coming together, and crossing over the green and the gray line. And so that showed that in patients with high risk disease, even quote unquote early disease, adjuvant immunotherapy can improve survival. The caveat there was that everybody got radiation also. So the NCCN guidelines and so forth restricted this approach historically based on whether or not the patient got radiation. Well, increasingly, we think about this cancer, radiation and surgery are local forms of therapy, right? So they only work what you pointed at. Radiation only works at what you pointed at. And as I told you, the big failure for us is systems-wise approach. This is what us as oncologists and physician scientists, this is what keeps us up at night, not the local failure. It's the systemic failure. It's coming up back in the peritoneum, lung, bone, liver, and so forth. And the ESOPEC study is important for you to be aware of. Again, complicated schema, but essentially it compared chemoradiation versus FLOT chemotherapy, which is the triplet chemotherapy, right? 3 chemo drugs that will control the system problems, systemic disease, and showed that radiation does not add to survival, right? Because again, it does not address the problem, which is the systemic illness. And in fact, FLOT, time after time, in gastric cancer and G-junction cancer and other, sort of two different studies, East, West, Europe, shows that chemoradiation is not as good as at systemic disease control, which it's intuitive. Why would systemic disease control work if you only pointed at the area that you're going to operate on anyway? And so the biggest, I think, leap forward in the last year has been showing that we can come up with a common denominator for treatment of systemic disease with intensified chemotherapy. And this is now doctors in Southeast Asia and South Korea, Japan, China, United States, Europe can all agree on that radiation for adenocarcinomas does not help address the elephant in the room, is that patients progress systemically. The disease comes back systemically, not in the local disease. So, and then what, right? But we want to use adjuvant nivolumab, but adjuvant nivolumab is only approved if you got chemoradiation, and we know that chemoradiation doesn't work as well as FLOT, and you do not want to give FLOT with radiation. That's a no-starter. It's too much. And so that's when the Matterhorn came in. The timing of it was actually quite good. We just presented it and published it in New England Journal of Medicine that showed that durvalumab, which is another form of immunotherapy, very similar to nivolumab or pembrolizumab. And I think one thing, if you sort of take away from today, is that there's a lot of options with immunotherapy. The most tried and true and effective therapies, anti-PD-1. It's a checkpoint inhibitor, so it helps your immune system get activated and see cancer for what it is, which is a morphed normal cell that's now is going to be a problem systemically and potentially kill a person. And so the immune system now can recognize it by taking the brakes off the immune system. We give the immune system permission to attack this mutant, not normal, but kind of pretending to be normal cell, right? And so durvalumab, pembrolizumab, nivolumab, all of these drugs are very similar. So, if you had one of them and didn't respond, or your loved one, didn't benefit from those therapies, other drugs, if from the similar class, are less likely to help unless there's some, sort of innovative combination with other checkpoints. So the Matterhorn study brought durvalumab in combination with FLOT to perioperative setting, and it is part of the NCCN guidelines. The way that we get drugs to the United States you can get it into the NCCN compendium, which is faster than usually FDA approval. And those, guidelines are living guidelines. And so they can be sort of controlled and directed by clinicians and experts in the field to change. And once it's an NCCN guidelines, the payers are under sort of pressure to cover it through the insurance companies, even before the FDA. And so, the background of Matterhorn, we discussed already, because we know that immunotherapy works in metastatic disease. We wanted to bring it to early stage disease, and we knew that doing it with FLOT is the most strategic option. There was another study, which we won't have time to go into, that used a similar approach, mostly treating patients in Asia, and used the non-FLOT approach, which is 2 drugs, capecitabine and oxaliplatin. So FLOT, remember, is 3 drugs. And although it was a close close positive result, it was not a positive study. With pembrolizumab is not used in perioperative setting, and FLOT is the optimal combination. This was a large study, 948 patients. So these studies are often difficult, to accrue in just one country. So we had over 20 countries and patients from 20 countries enrolled. And so it was a huge lift, but it really accrued fast despite the global pandemic and despite the fact that we, for the first time, tried to convince the Asian surgeons to agree to give FLOT perioperatively, and B, to enroll really patients both with gastroesophageal junction and also stomach cancer, right? Historically, sometimes, these studies were totally separated. Southeast Asian patients went on one study, US patients went on the other study, and there was, again, it's difficult to move the field forward, and it's also confusing to the pharma partners in the future if they're trying to develop a strategy, but also the patients, if there's such variability. So to have this study to create this common denominator, and additionally, of course, to have the durvalumab in the clinic are probably the main 2, important breakthroughs for this. A word about endpoints, right? So when you design a study, you need to be very strategic and careful and have a clear intent of how you're going to determine whether a study is positive and negative. I just told you about a negative study that also, was a big lift for patients and caregivers and industry, and it was negative. And some of it was because it was not designed correctly, right? So you have a certain number of patients, you're trying to answer a certain question. And if you spread your questions too thin, you don't, multitasking doesn't work. You really have to focus and try to answer the most important question, which in this case was event-free survival. We designed the study with a hypothesis that if we give a really modern regimen, which is FLOT, and add immunotherapy, we can improve survival of patients, meaning that the patient's cancer will not return, event-free survival. But also we looked at overall survival and complete response rate in patients who had this regimen. The rate of complete response is probably the highest that's been reported in any study. And speaking to all the, although with all due respect, surgery may be important right now, but I'm hoping in my lifetime as an oncologist, we can let people live with their disease, without their disease, with their organs. So non-operative management. And, actually I was trying to be respectful, but I was also writing a big Department of Defense grant going in next week, focused on non-operative management and trying to understand from the beginning. I showed you these survival curves, and you'll see the next set of survival curves. There's always at least 20% of patients who are fine 5 years out, 10 years out. And perhaps in those patients, if we know who those patients are early on, we can de-escalate therapy so they don't look like cancer patients getting through cancer therapy, but they, if you see them on the street, you wouldn't even know that they're sick or on treatment. And B, we can leave them with their organs intact, cancer-free, as opposed to, because the face of cancer patients, it's not at least in our clinics now and increasingly, it's not, it's people who will be living with this disease for decades. There are people in their 40s, 50s, And again, we got to mitigate some of the toxicity. So what we look at in some of these success metrics is the likelihood that the surgery is, sort of compromised. These are curative intent patients. So surgery is still the gold standard for cure. So we don't want to compromise any chances that you will go through surgery successfully. And this study showed that you can give patients something as aggressive as durvalumab and not compromise cure. And we also showed that, this patient population can be quite advanced. These are patients with T4 tumors, meaning that the tumor is going through the muscle, all the muscle layers into the sort of the external lining of the stomach. And close to, 2/3 of them have node positive disease. So we were not cherry picking these cancers for very early stage. And once again, these are all the same cancers. Adenocarcinoma, there were no squamous cell cancers involved. And these are the survival curves that sort of made all the popular press and also has been, featured in several high-profile general medicine publications. So we have an orphan disease, right? So, Sam and I talk a lot about it, how almost impossible it is to get a paper into New England Journal of Medicine because most people, most publications, these journalists care about citations and they go after high profile, frequent, diagnosed disease such as colon cancer, lung cancer, breast cancer. So for New England Journal of Medicine to accept this paper and they understood how important it was. So we were able to get a simultaneous publication in New England Journal of Medicine. And this is a trend now for, we want to have a spotlight on our disease because that's how research dollars, both federal, but also philanthropy, and more importantly, pharma, now they prioritize drug development in this disease because they understand that you can be successful and you can help patients. So the survival curves clearly separate. As you can see here, we like to see an early separation in the survival curves as early as 3 months and a sustained separation. And this plateau on the survival curves is always great to see. The other important part was we always look at the subgroup analyses. One important subgroup is obviously patients who are maybe on the older side. We had such a wide range of clinical trial enrollment in the study. The youngest patient was 18 and the oldest patient was 84. So, there was a wide range, and we see that even patients greater than age 65 were able to tolerate this regimen. It's important to see that patients with low PD-L1 expression in their tumor. So I know you hear about PD-L1 a lot, and there's different ways to look at it. TAP is one of the ways, and combined positivity score is another. But it's the same, basically, test. And PD-L1 low patients also benefited, and gastroesophageal junction patients benefited. So, which is the location of the cancers that we mostly see in the Western population. Of course, the overall survival data is still pending and maturing, but it's nice to see that survival curves started to separate, and we're hoping to be able to update the academic community on the final OS analysis this fall at the upcoming European Society of Medical Oncology meeting. But as I mentioned, pathologic complete response rate is meaningfully improved in this population, again, giving us hope for non-operative management if we continue to build on this trend. So the secondary endpoint, and this is a small but important point, patients ask me often after they have complete resection and they come in to see me in clinic, they say, Dr. Janjigian, why do I need to get more treatment if the tumor is already out of me? Well, it's because, again, of this impact on micrometastatic disease. And we see that even in patients with R0 resection, the disease-free survival is still improved if you continue therapy. Treatment delivery is important, but I think for those oncologists that don't see gastroesophageal cancer often or as dedicated as some of us do, understanding that for each patient each individual dose. It's okay to dose reduce. It's okay to take a few days off and come back. I think it's important to understand the FLOT regimen is not an easy regimen, and getting through this with hydration, growth factor support, dose reductions. If you're having neuropathy, if you're having difficulty with this regimen, ask your doctor if it's feasible to do a dose reduction. And the answer is yes. And if they're saying no, have them call me. But the most common side effects, what we see is that it's chemo side effects. Immunotherapy is okay, but most patients will have some sort of side effects, and some of them are more permanent than others. Your hair will grow back. Your blood counts will come back if you with a white blood cell shot. Neuropathy is probably one of the most kind of sneaky side effects that you have to watch out for and not minimize. So many of my patients pretend they don't have neuropathy, but I get it out of them eventually, but you really cannot underreport it, because what happens is some patients really in their neuropathy can get worse before it gets better, even once you dose reduce. And your nerve endings are important limited resource. So we don't want to burn them out because that would limit our options for future therapies. So I think, how do we prioritize the future of these type of therapies? We built on immunotherapy and FLOT. And, we're doing, for example, a clinical trial at MSK, and MGB and other centers are also participating. This is an investigator-initiated study to look at HER2 with chemoimmunotherapy, same way as we did in metastatic disease with KEYNOTE-811. We're now bringing it in early stage disease. There's subpopulation of patients that we can definitely cure with chemoimmunotherapy alone. Patients with microsatellite unstable tumors, Epstein-Barr virus-related tumors, subsets of HER2 positive tumors, and then the rest, we just need to chip away at the pie really diligently and slowly together. I think the only way we will find these small populations if patients are proactive and vocal and asking for their test and their biomarkers to be done on their tumor. And I've never had a patient tell me, I don't want another biopsy. So I think there's this mental block sometimes from the oncologists to offer it an endoscopy to get fresh tissue. But what I tell my patients is I can't go into a battle with outdated maps. So I really need to understand what is the biology of your cancer before and after certain treatments. And we can now target a lot of these and monitor a lot of them using blood-based biomarkers, both of immune response, but also circulating tumor DNA. And, I get probably the number one question I get asked from my, I have a family of scientists. My brother's a theoretical physicist, so he's the smart one in the family. And he always asks me, so when are you going to cure cancer? How are you going to cure it? And really the way we cure it is not for this big push that everybody's going to get the same treatment and we're going to cure it for, everyone in the same way, but in a very systematic way, chipping away at these subsets that for each individual patient, my definition of cure is if they live with their disease, even metastatic or advanced disease, 5 years, 10 years, and even if it means that they need some sort of chronic suppressive therapy, I think that would be a game changer for many of our patients. And this is how we prioritize the biomarkers that I mentioned therapeutically. Let's say you hit the jackpot and you have all of these biomarkers, right, in your tumor. How would you prioritize them? Well, microsatellite instability is the first one. In terms of efficacy outcomes and predictive value, HER2, and then PD-L1, and then Claudin. And then the good news is that for the top three, you get immunotherapy with chemotherapy or without, depending on, how well you tolerate the chemotherapy. And if with number two, you add HER2 targeted agent. Claudin inhibitors are, really rapidly evolving right now in the field. And so I think we're going to improve on how we target Claudin in the clinic, and we're doing a lot of perioperative studies as well in that setting. So thank you for your attention. I mean, it's amazing to see the evolution, and come visit us in New York. This is my group in New York City. Thanks.
Awesome. Thank you very much. Definite message of hope for the non-metastatic patients. We've got a few minutes for questions. Then I'm going to have Dr. Cleary come up. Yes, go you, Sally, you first.
Probably just semantics, but sorry, when you first started and you talked about the exclusion or more importantly, the patients you put into the study, it was the non-metastatic patients, correct? So I guess, and this is just me not understanding, if you had a patient that was diagnosed with cancer in their lymph nodes, you don't consider that a form of metastasis?
Depends on where the lymph nodes are. So we have different lymph node stations and depends on the tumor location. Most of the cases, lymph node metastasis only is not considered metastatic unless the lymph nodes are located outside of the area. I think about lymph nodes, they're like a canary in a coal mine. So if the lymph nodes are supraclavicular or really lower down in the pelvis, sort of below the kidney level, they are considered to be more advanced, and that would probably preclude enrollment in some of the clinical trials for operative management. But we do sometimes operate on those patients later on.
Yeah,
thank you.
Totally agree. Yes, you are next.
For you. Do you think radio tracers are coming? Do you think radio tracer PET are coming online for diagnostic purposes? And if so, is that going to change the landscape in terms of, similar to HER2 low? And second, I guess, radiopharmaceuticals, what role are they playing in third? So I guess, is abscopal effect sort of a myth?
Yeah, so I'm glad you brought it up. So we've used functional imaging in this disease for quite some time. We know PD-L1 PET is actually FDG PET, which uses fluoridated glucose, sugar molecule, is quite prognostic and predictive of survival, right? So if you have FDG avid disease and you got chemo perioperatively and you didn't have any reduction in FDG in your primary tumor, we know that additional chemo doesn't help you, for example. So using that premise, we've developed at my center different tracers to understand the biology of HER2 positive disease. For example, we have a HER2 specific PET that we've developed. And not surprisingly, what we see is quite a bit of heterogeneity. 80% of patients have difference in the HER2 uptake, and that's predictive of outcome with anti-HER2 therapy. We've developed also similar PD-L1 PET. So we know those PETs are useful. We're developing a Claudin PET. But beyond that, to your point, I think developing a ward target to image and then using these PSMA-like or lutetium-like approaches to then use, for example, an alpha emitter or some form of warhead to target the tumor is where the field is moving. I think that's a huge sort of separate topic, but suffice it to say, most of the patients, eventually their cancer will become chemotherapy refractory. And in most patients, their functional status is still excellent, and they could, still go on a therapy of some sort. And often we don't have sufficient therapies to control the disease. And so that's where theranostics could, and potentially in patients with bone-only disease and so forth, could be important. And we're looking at that. In terms of abscopal effect, I think a radiation abscopal effect, I think is unlikely, but this abscopal effect of, injecting, for example, intratumorally, a certain potent immunotherapy to see other, the immune response potentiate effect on other metastasis. We have began sort of that work, and that's potential. And yes, I think there is a lot of opportunity for these type of studies. The challenge, I think, and for me, what I struggle with is for those type of therapies, this is not going to trickle down to the bigger patient population who don't have access to tertiary cancer centers. And, our patients here are so fortunate to be able to travel, to get second or third opinion and so forth. But that's the reality that most of our patients don't have access to that. And then I think that's why these advocacy groups are so important. So at least, we have patients come to MSK from all over, just to get like a reality check of what are the options. And again, we try to train fellows and then send them back, not keep them, send them back from whatever state they came or country they came from, just again, to just raise the quality of the median, because some of these sort of fancier new therapies won't help because my biggest pet peeve is that some of these progresses we make in the clinic never make it to the average patient.
Yeah, totally agree. I saw you get the last question, and then we'll go to the next talk.
Yeah, thank you for sharing. One question, and I know it's related a little bit to the therapies, but just curious, from your perspective, what is the outlook for gene therapy for GI cancers, and whether it's a scientific barrier or is it more of the cost or access?
I think right now, federal funding and the general vibe of the sort of the worry about how the state of research is probably the biggest barrier, because some of these gene therapies research, it's not feasible for them to be done through big pharma. So it has to be people like me and Sam, or folks at smaller, tinier biotechs doing this research, because these type of trial, preliminary, even lab-based investigation is very tedious and high fail sort of. So unless philanthropy and other sort of angel investors fund it, I worry that we have a major delay in because it's really not a straightforward area to explore for solid tumors and GI in particular.
Yeah, no, thank you very much, and thanks for making the trip up from New York. All right, we're down to the end of the day, and so we just were talking about non-metastatic patients, so patients who are down a curable path where surgery is maybe going to be part of the plan. But as we've heard all day, unfortunately, there's also a large portion of people who are stage 4. And the first slide that Dr. Janjigian showed was a trial that was partly led by Dr. Cleary. So Dr. Cleary is a friend and colleague across town at Dana-Farber. We've shared many patients. I've maybe even sent a few of you over to him a few times, but he's going to bring us home talking about advanced disease.
Thank you. It's really wonderful to be here. I really want to thank Sam and the organizers from Debbie's Dream for having me here. And as Sam mentioned, I'm going to talk about biomarkers today. And I really feel like over the past few years, there's been a lot of progress made in gastroesophageal cancer. And that progress has really been made because we stopped treating all of gastric and esophageal cancer as one disease and started realizing that there was many sub-diseases, and the way we did that was using biomarkers. These are my disclosures. And so when someone has an inoperable esophageal or gastric adenocarcinoma, the way we treat them is we can't use surgery. We'll use radiation to palliate symptoms, but by and large, we want to use treatments that can go all over the patient's body to treat the cancer wherever it is. And for the longest time, what we've been doing is using chemotherapy. Can you hear it now?
Easy.
All right. Perfect. Thank you. So what we've been doing for many, many years is using chemotherapy to treat patients with inoperable esophageal or gastric adenocarcinoma. And the chemotherapy we've been using is FOLFOX, although in certain circumstances, XELOX, they're both equally as good. And those chemotherapies are made up of 5-FU, leucovorin, and oxaliplatin. And many of you probably know these chemotherapies, but really just to talk about the side effects, these chemotherapies, and Yelena was talking about this, neuropathy, and the neuropathy can be very significant and it can be permanent. So it's something we have to watch out for. And patients who've gotten oxaliplatin know that you can be very sensitive to the cold, especially for the few days after you get chemotherapy. But in terms of improving outcomes for patients with gastric and esophageal cancer, what we've really been leaning on has been biomarkers. And so what are biomarkers? To me, what a biomarker is, it's a test looking at a certain characteristic of the tumor. And the relevance of it is it helps us select the best treatment for your cancer. And so one type of biomarker we use is immunohistochemistry. And so what immunohistochemistry does is it actually takes the tumor sample, and you can see here, these are cancer cells. And what you do is you stain these cancer cells, and these cancer cells can be obtained either through a surgical specimen or a biopsy, and you stain them with an antibody that has a color label on it. In this case, the color label is brown. And you can see here that the highest score here is 3. And so this has a very, very high amount of brown, which is great. Whereas, oh, you'd prefer? Oh, super. Whereas these tumor cells really didn't have much of the protein being assayed, in this case HER2, and that's why it's so low. So really, immunohistochemistry just allows you to use an antibody to see how much of a protein a certain tumor has. Another really important biomarker is looking at DNA and RNA. What are the genetic changes of the tumor? And one thing we know about all cancers is that all cancers have genetic alterations that weren't there when you were born, but are there in a tumor. And knowing what those genomic alterations are can really help us select the best treatment for you. We've been using DNA next generation sequencing for over 10 years, but more recently, we're also learning that in addition to DNA, testing for RNA is also important. So you really want to have your tumor profiled with next generation sequencing, looking at both DNA and RNA. So we were talking about biomarkers and in particular next generation sequencing, and really just to say there's many different next generation sequencing platforms, but you want one with both DNA and RNA, and examples of vendors include Caris, Tempus, and Foundation Medicine, but there's actually others. Finally, the other biomarker test that's important is using blood. So tumors can shed DNA, and looking at that shed DNA, something we call circulating tumor DNA or cell-free DNA, has really been a way to quickly look at genomic alterations. And again, vendors that do this, there's many of them, and they're all good. Garden 360, Foundation Medicine. I like circulating tumor DNA for a couple of reasons. Number one, it gets me the answer quickly about what genomic alterations are there, but also it helps me look at things like resistance. So Sam and I have shared some patients where we're interested in why a therapy stopped working in a patient, and we're able to ask that question with cell-free DNA. So where biomarkers have been particularly important have been in helping us select which patients should get immunotherapy. And I'll say in my career, the most transformative therapy that's come online has been immunotherapy. And really to talk about the way immunotherapy works, when a cancer develops in a person, what's supposed to happen, we think happens to the vast majority of cancers, is the immune system supposed to attack them and eradicate them. So the only way for a cancer to persist with this immune surveillance is they have to evolve ways of becoming camouflaged from the immune system so that the immune system won't kill them off. And so that's why we call in many immunotherapies checkpoint inhibitors, that the immune system often is held back by a checkpoint that the cancer evolves, and that checkpoint therapy gets rid of those checkpoints and allows the immune cells, and in this case T cells, to kill off the cancer. The most famous immunotherapy, and the one that's really worked most broadly, and the one we use most commonly in gastroesophageal cancer, has been PD-1 directed therapy. And the way PD-1 directed therapy works is that, again, ordinarily, T cells, immune cells, should kill off cancer cells. But cancers can evolve to become camouflaged from the immune system And one of the ways they can camouflage themselves from the immune system is PD-L1. And I really want to highlight PD-L1 because that's really one of the most important biomarkers that we'll talk about in one of the upcoming slides. So PD-L1 can camouflage the cancer from T cells, but with the drugs we're using that inhibit the PD-L1 system, that camouflage system stops working, and then the immune cells can go and kill the cancer. So as Yelena was mentioning, when I think about immunosensitive cancers, MSI-high cancers are really the most immune-sensitive cancers. And one of the reasons we think that MSI-high cancers are so immune-sensitive is that MSI-high cancers, and that's what this diagram's trying to get across, is they just have many more mutations than normal cancer cells. And the immune system has a really, really hard job. The immune system has to see our regular organs like our heart and our colon and know not to attack, whereas seeing something foreign like a bacteria and knowing that it should attack. So the more different a cancer cell can look like from our normal cells, the easier it is for the immune cells to kill them. So MSI-high cancers have many, many more mutations than ordinary cancer cells, making them different from normal cells and allowing the immune cells to go and kill them. When I meet a patient with an MSI-high cancer in clinic, really there's a few different ways to treat these patients. I think it's reasonable to give nivolumab, ipilimumab. You can give single agent pembrolizumab, or you can give FOLFOX with something like nivolumab or pembrolizumab. My preference is, and again, there's no data about which is better, but my preference is to treat these patients with nivolumab and ipilimumab. Probably the most important biomarker, though, in determining where patients who aren't MSI high, which of these patients should get immunotherapy is PD-L1. And really the concept here, and this has been shown not just in gastroesophageal cancer, but really all cancers, is that you want a cancer that's positive for PD-L1 by immunohistochemistry. And those cancers that are positive for PD-L1 have a higher likelihood of responding to immunotherapy, whereas PD-L1 negative cancers really have a very low chance of responding to immunotherapies. So when I see a patient that is a PD-L1 positive gastroesophageal cancer, oftentimes what I'm thinking of doing is taking the FOLFOX, which we always give, and then adding an immunotherapy to the FOLFOX. And there's several different immunotherapies that are reasonable to use. They're all PD-1 targeting agents. You could add nivolumab to the FOLFOX, pembrolizumab to the FOLFOX, or tislelizumab to the FOLFOX. Now, one other biomarker that comes up, and Elena's been really a pioneer in this space, has been HER2 amplified tumors. So when we see a HER2 amplified tumor, really what that means is that there's a protein on the surface of cells that is amplified, that there's many more copies than should be there. So for example, some patients I have that have a HER2 amplification, we all should have 2 copies of HER2, one from our mother, one from our father. Some cancers will have 100 copies of HER2. And those cancers will be very, very sensitive to this HER2 antibody. And so what we had been doing for many, many years for HER2 positive tumors is we were taking patients, we were giving them FOLFOX, and then we were adding trastuzumab, Herceptin to FOLFOX, and we were seeing nice outcomes. I should say that the way we monitor patients getting HER2 therapies is we have to just watch their heart. We just have to do echocardiograms. Fortunately, it's very rare to have cardiotoxicity, but you just have to watch their heart. But otherwise, what's nice about HER2 therapy is it works really well with very low chance of side effects. So this is how we've been treating HER2 amplified tumors for many, many years. But really, the question in the field was, can we do better than this? Can we do better than just adding the HER2-directed therapy to FOLFOX? And so Yelena and colleagues did a trial, and this trial actually eventually uses 2 biomarkers. So the first biomarker is looking if they're HER2 positive, but then they noticed that the patients that were HER2 positive, but also had PD-L1 positive tumors, did particularly well when you gave them FOLFOX, Herceptin, and you added in pembrolizumab. So today, the standard of care for a patient that has a HER2 amplified tumor that's PD-L1 positive is you treat with FOLFOX, trastuzumab, and pembrolizumab. one of the reasons that HER2 has just been such a wonderful biomarker in gastroesophageal cancer is you can treat, as we just said in the last slide, with FOLFOX, pembrolizumab, and trastuzumab in first line. But when that therapy stops working, we still have another biomarker-directed therapy that we can use in second line. And this is a type of treatment called an antibody-drug conjugate that's really been a wonderful strategy in oncology. And to talk about antibody-drug conjugates are an antibody, but what's different from other antibodies is these red dots here are chemotherapy molecules. And so what we're doing here is we're giving an antibody, but we're also using the antibody to deliver the chemotherapy straight to the cancer cells. In many ways, I think about this as a guided missile. And so with trastuzumab deruxtecan, you're giving the HER2 antibody. It has the chemo on it. It binds to HER2, and then the chemotherapy goes straight inside the cancer cell. And what's wonderful is people can get first-line FOLFOX, trastuzumab, and pembrolizumab. Their cancers can get resistant to that, and they still can respond to trastuzumab deruxtecan. So this is really a nice option. The one thing I should add is the one Achilles heel of this drug has been shortness of breath. That patients who get this drug can get what we call pneumonitis, and they can get short of breath. So if you get this drug and you get short of breath, please just tell your doctor. And the new kid on the block in terms of biomarker-directed therapy has been Claudin 18.2. And this has been wonderful because not all of our patients have been able to get biomarker-directed therapy. So it just gives another option for patients. And so what Claudin 18.2 is, it's another protein that on cancer cells are expressed on the surface. And what we're able to do is we're able to do immunohistochemistry and see which patients have a lot of Claudin 18.2. And so patients that have a lot of Claudin 18.2, when we look in the laboratory, they have more than 75% staining. So they either have moderate or strong staining. So these patients with a lot of Claudin 18.2, these patients are potentially a candidate for Claudin 18.2 directed therapy. Whereas patients with weak staining, you really don't want to give them an antibody to Claudin 18.2. And the antibody that's currently in clinic and is FDA approved is called zolbetuximab. And this antibody binds to Claudin 18.2 and it's been really effective at enhancing the efficacy of FOLFOX. So it's really a nice option. The one issue with zolbetuximab has been nausea. But as we're getting more experience with this, we're really learning what anti-nausea meds to give. And so if you get this drug, just talk to your doctor. And again, we're starting to use anti-nausea meds better to make this more tolerable. So Yelena brought this up in her talk too. And one of the nice problems we're having now for patients with gastroesophageal adenocarcinomas is some cancers can have more than one biomarker. So how do you look at this? And this paper was done by a colleague of mine named Li Zhao at the Brigham, and she saw that several tumors can have more than one biomarker. And so I will say, how do you treat patients with more than one biomarker? The honest answer is we don't know yet, and we're still trying to get data, but I'll tell you how I approach this. And what made me feel better is this also is the same list and prioritization that Helena gave on her slide. If a patient has an MSI high tumor, those patients should be really treated with immunotherapy. That's really the strongest biomarker, and those patients have wonderful outcomes. Again, with HER2-directed therapy, that's really my second choice. If you have HER2-amplified tumors, we really should go down that path. If it's PD-L1 positive, because immune therapy, those patients can have very durable responses to chemotherapy and immunotherapy. That's my third choice. But if it's PD-L1 negative and negative for all the other biomarkers, but positive for Claudin 18.2, yeah, zolbetuximab is a great option. We should be doing that. Finally, and in the beginning of the talk, we talked about next generation sequencing. And this is really important when you get to a point in your treatment and your oncologists are looking for other options that aren't FDA approved. And Sam's been a leader in this. One of the things Sam gave a talk here in Boston on Monday night talking about different trials he has. And what he's done is he has lots of different biomarker-directed studies that aren't FDA approved, but if you find them on next generation sequencing, he'll have a study for you. And so the idea is that we're going to use next generation sequencing to find alterations that we don't have FDA approved therapies for, such like KRAS amplification, MET amplification, MTAP deletion, NTRK fusions, but the list is much higher than this. And we might have some experimental drugs for this, and this next generation sequencing will allow you to be eligible for that trial. And again, prior to having next generation sequencing, we would just randomly put patients on trials and our outcomes were horrible. But now that we have next generation sequencing and we can match the right patient with the right drug, the chance of you responding to a clinical trial really goes up. So in conclusion, I really feel like a success, a big, big success in gastroesophageal cancer over the last few years has been using biomarkers to help us guide patients. So please partner with your oncologist to make sure that you get biomarker testing, and then talk to your oncologist about which treatment is best for you using these biomarkers. And then finally, I just wanted to thank Debbie's Dream. A lot of my patients have benefited from these talks, the webinars, all the information online. It's really been a great service to the community. So thank you.
We have a few minutes for questions. Yes.
CAR T therapies, and whether are those relevant?
Well, such a great question. So the dogma had been that CAR T cells are really good at working against liquid tumors like lymphoma, leukemia, and myeloma, but it hasn't really worked in solid tumors. Fortunately, we're starting to see data that maybe they do work in solid tumors. And at the National Oncology Meeting, ASCO in June, there was a trial from a Chinese group using a CAR T cell against Claudin 18.2, and it did show some efficacy. Again, it's not ready for prime time. It's still in experimentation, but I'm hoping over the next few years, we are going to start seeing results from Claudin 18.2. So I guess the way I would answer that is, I think it's still in the research sphere, and I think we still have some more work to do, but I hope in years to come, it'll be more widely available.
Yes.
Question. Can you comment on the percentage of patients at your institutions who have baseline FDNA versus referrals you receive and uptake outside of your institution? And I guess curious what you're seeing both anecdotally and in the literature about mutation drift. And I hadn't thought of it. I don't know if there's a literature, but MSI evolving over time status, how that changes.
Oh, these are great questions. So this one's a little bit technical, but especially with the RNA, DNA. At my institution, everyone's been doing next generation sequencing, but honestly, we've been using a DNA only platform. We're actually going to be shifting next week to do it using a platform that uses both DNA and RNA. We really feel like that's important. In terms of, one of the luxuries at working at a place like MGH and working at Dana-Farber and Memorial Sloan Kettering is we actually, on all the pathology reviews in our institution, they do all these biomarkers automatically. I've been impressed that community hospitals do most of the biomarkers. Occasionally with biomarkers that are just coming online, like Claudin 18.2, I don't see them. But generally speaking, in New England, where I practice, I do see a lot of biomarker uptake. And sorry, I forgot the end of the question. Yes. So the MSI. Thank you. Yes. You probably heard my enthusiasm for seeing MSI high tumors. I have to say, I have not seen a tumor that's changed from being microsatellite stable to MSI high. It's just not something we see that changes. There's been some experimental approaches to try to do that, but none of them have really worked consistently. So unfortunately, we haven't seen that.
It's got a really good question.
Yeah.
Now you mentioned GLP-1 cancer protecting itself from the immune system. So do all tumors have other inhibitors? Because what I'm trying to get into is the fact that why we are not finding the specific inhibitors and targeting all of those via the immune system. That's number one. And number two, instead of actually targeting all these different biomarkers, why don't we actually build a profile for each patient on that specific cancer cell and then target the immune system to that profile for that patient? Is that just money issue on this regard or something more fundamentally challenging?
So these are tremendous questions. So thank you. When PD-1 inhibitors came online about 2015, I think the hope was exactly what you said, that there are other checkpoint inhibitors such as LAG-3, TIGIT, TIM-3. And our thought was, wow, if we just combine PD-1 with a LAG-3 or a TIGIT antibody, we'll see great responses. Well, in melanoma, we're actually doing that. So in melanoma patients, they treat with PD-1 and LAG-3, and that's actually helped hitting two different checkpoints. In other cancers, it's been tougher. And I wonder, for example, LAG-3 has been tested in gastroesophageal cancer, and the results have not been promising. And I wonder if we just haven't been smart enough about how to select the right patients, or perhaps we don't have the right drugs. So I still think there's going to be some trials in that area, but I have to say over the last 10 years, there's been an enormous push to do that, and it's unfortunately been a failure. But hopefully we'll think of some creative ways to do that. Sorry, could you ask the second question again? Yeah. It's a great question. And I think what we're trying to do with biomarker testing is exactly that, is try to see, realizing that all gastroesophageal cancers aren't the same, because that's how we were doing trials 20 years ago. We treat every gastroesophageal cancer patient the same way, and now we're using biomarkers to sort of put them into subdivisions. Moving beyond the current biomarkers, finding even more intelligent biomarkers, I think that's really important. Sam has done a lot of work with scientists trying to do that. Progress there, we're still working, so I'm hoping maybe I'll have a better answer for this question like in 3 years, but right now we're sort of stuck here, and using things like artificial intelligence would be great, but we're not quite there yet.
Get the last one.
Thank you. In regards to the circulating tumor DNA, does that type of, I'm familiar with Signatera, I think is one of them. Does that type of test find the micrometastatic cancer?
This is a tremendous question. And the cell-free DNA assays that I was talking about, vendors like Garden 360 and Foundation, what they do is they look at the mutation. So they'll look at your tumor, and the report they return to your physician is they'll say, you have a KRAS amplification, you have a P53 mutation. So that's helpful in getting mutational information about the tumor. The really nice cell-free DNA assay that you talked about is Signatera. And what that's looking at is seeing, is there any cancer DNA in the blood at all? Because you can imagine that a patient who's cured should have none, whereas a patient who has residual tumor that we might not even be able to see on scans, you might see positivity in an assay like Signatera. So there's two different cell-free DNA assays. One that gives feedback about what mutations there are, and then assays like Signatera will just tell you, is there any cancer cells there at all? And in the metastatic setting, we could use assays like Signatera just to see, is the tumor getting better? If the tumor is getting better, so your Signatera titer was 100, maybe it'll go to 10. That's a great trend. Whereas, is your tumor getting worse? It started at 100 and is up to 1,000. So we use it that way.
Well, I think we're close to being kept on time. It's a little after 2:15. One, thank you to Debbie's Dream and all the staff, security people, everybody sort of working the event today. Definitely could not have been done without you guys. Two, thank you to you all for taking time out of your day. I know it's a beautiful Saturday, so hopefully we didn't take the whole thing away from you. And I look forward to doing this again. Hopefully it was helpful for everybody. People who spoke and the patient panel, we want to get one picture, but everybody else, feel free to make your way back home and enjoy the rest of the day.